Good afternoon, everyone. Hello. Welcome. We're going to start our program, our educational portion of the program. We're so happy to see you today. We hope that you enjoyed the luncheon, and we very well may have some others that are filing in during this educational program time. But I'm really looking forward to our program this afternoon. My name is Danielle Ellinas. I am the Director of Operations at Catamount Medical Education, and I'm here with my colleague Alexa Lasik, and we're here to help you with whatever you need today, okay? But on behalf of the Consortium of Multiple Sclerosis Centers and Catamount Medical Education, I'd like to welcome you to our 4th annual More About MS program, Achieving Health and Happiness While Living with Multiple Sclerosis. And we also want to welcome our live streamers. We have almost 400 total signed up for this program today, and about 300 have signed up for live stream. Yes, that's amazing. So we're welcoming them, and I did want to say that if you are live streaming today, please look at the top of your screen, and there's some tabs up there with resources. There's a workbook that you can download, and the slides are on there as well. And those of you who are sitting at tables, you've already seen, I'm sure, the workbook and the different resources that are on the table. You also see probably some fun things like numbers and pictures, and my colleague Alexa will be explaining all that to you a little later during our interactive portion. So this program would not have been made possible without the generosity of our supporters, and we just want to thank Bristol Myers Squibb and Biogen for that. Would you give them a good hand? So as we move through our program today, you'll get to see us. We will acknowledge our supporters in a special way. So at this time, I'd like to introduce our chair and the first presenter. Look, he's already up here. He's ahead of me. I think was that the cue for them to play the music for me to be finished? All right. Well, over the last 3 years, I've had the honor and privilege of working with Dr. Shapiro to plan this meeting, and to work with the person who founded the first comprehensive care center in the U.S. is quite an honor, actually, in itself. But he's served on many national and international boards of MS societies. He's received multiple prestigious awards, and he's a MS Hall of Famer. He has so many accomplishments behind him, and yet he still chooses to devote his life to teaching and talking and teaching you and us about MS, which is amazing. And so he could be doing anything today, right? He could be fishing. Retired, right? You're retired. He could be watching TV. He could have stayed home today. He could be sailing a boat. Oh, golfing. Yes, he could be golfing today, right? But he's here with us, and I think that's pretty unconventional. And so I was thinking about this because last week I saw the movie Top Gun: Maverick. So anybody excited to see that? The first one, yeah. The first one came out in 1986. Isn't that unbelievable? And in it, Tom Cruise, he's called Maverick in the movie. That's his flight name. And so he's asked to train the most elite Navy fighter pilots on the planet. And they're called Top Gun. And they have a critical mission that they have to do. And he's upset because they see him as an old man now. Tom Cruise as an old man, Maverick. And you know what? He's upset, and he says, I want to fight with them. I don't want to just teach them, but I want to fight with them. So I was thinking, in a way, I feel like, Dr. Shapiro, you're a maverick. You are a maverick of MS. And he's worked so hard to put the More About MS patient program together for you, and put together this wonderful team of faculty that you're going to get to meet throughout the afternoon. And might I say that if there was a Top Gun in MS, these guys, the faculty that are presenting today, would be part of that elite group. So without further ado, would you welcome our maverick, Dr. Randall Shapiro. You're welcome.
Is this microphone live? Because I'm not, yeah, okay, there, now I can hear it. Yeah, good, thank you.
We're just going to acknowledge a supporter.
Yeah,
Okay.
oh yeah, okay.
So this time we just want to acknowledge our first supporter.
Then you'll hear from me. I promise.
The Consortium of Multiple Sclerosis Centers and Catamount Medical Education would like to thank Biogen for their generous support of this program. This support has made it possible for us to provide this valuable education program for people living with MS and their care partners.
Thank you. And thanks, Danielle, for all the work that you put in on this as well. It's my pleasure to be here and take care of our 4th annual patient program about multiple sclerosis. We're going to have fun today. Our faculty, I just surveyed them, we have over 200 years of MS experience in managing multiple sclerosis and working with people who have multiple sclerosis. I don't think you're going to find too many faculties with that much experience in front of you, and we're here to answer questions for you. This, as I say, is our 4th year. I'm going to get relaxed, I think, take off my jacket and be able to exercise with you a little bit along the way, but as we put together these programs over the years, we've asked you folks to send us questions about what you'd like to hear about. And some questions got to be recurrent. I started seeing them over and over again. And some of them were fairly basic questions about multiple sclerosis, even like what it is and where did it come from, and things of that nature that we really hadn't tackled in our previous programs. And so I volunteered this year to do a basic talk on multiple sclerosis. So for some of you, this will be a review. I can guarantee there'll be some takes on it that are different than you've ever had before, but for some of you, it may be new information. I called this program The Questions You Asked, the answers you may or may not want. Maybe they will be a little bit different from the way you've been thinking about multiple sclerosis in the past. The first question that came up was, when was MS first described and first diagnosed? You know, multiple sclerosis is not a new modern disease. We can make it sound modern by talking about all kinds of immunological abnormalities that go on in the body in multiple sclerosis, but it's not a new or modern disease. As a matter of fact, it may have been present in the Bible. As you can see here from Luke chapter 7, verse 22, at that very time he cured many people of diseases and afflictions and evil spirits, and he gave sight to those who were blind. And he answered them and said, go report to John, see what you have seen and heard. The blind receive sight, the lame walk, etc., etc. Now, that may have been a reported case of multiple sclerosis. We don't really have any way to know for sure, but it could very well have been in that era. But the first reported case that we're aware of was in 1380, and I was there. In 1380, I saw Saint Lidwina, who was born in Holland. She had slipped on the ice and broke a rib. She was said to be a person who took the sins of others and put them upon herself. Very, very kind-hearted person. I was there in 1794 when Augustus d'Este was born as well. You can tell that I've been around. I've got the mileage on me. And Augusta was an early case as well that was known as multiple sclerosis. He was the grandson of King George III, and he was illegitimate, so he was not talked about very much. He was a very sensitive kid and lived a relatively short life and died in 1848. The father of neurology was my father, Jean-Martin Charcot. He gave 3 lectures and described multiple sclerosis in French, and I'm not going to bother you with the pronunciation because I'd show my ignorance. But suffice it to say Charcot was my father. You can tell that he was my father because we share the same nose. Yeah, there he is. Multiple sclerosis, as you know, is a disease of the immune system. The immune system is the system in the body that fights foreign substances. In AIDS, the immune system is underactive, and in MS, the immune system is overactive. This immune system is made all over the body. It's made in the tonsils. It's made in the thymus gland that sits over the heart. It's made in the bone marrow. It's made in the spleen, and it's made in the lymphoid tissue of the gut. Where it's not typically and normally made is in the brain and spinal cord. It's not typically made there. When it is made there, something is wrong. So you can see it's made all over the body, except in our nervous system. So for that immune system to attack something in the nervous system, it's not a simple process. Things have to happen to make it work. And the first thing that has to happen is that something has to program that immune cell to want to attack something it hasn't seen before. In the case of multiple sclerosis, it may be myelin that we'll talk about. It may be the cell that makes myelin, the oligocell. But something has to program it. That foreign substance is called an antigen. And the immune cell gets programming that antigen, and it has to present it to the immune system. It does that by going into the, let's see if this works here, if I push this button here. Those of you who are streaming, I don't know what you're not going to see this at all, but those of you who are here can see this immune cell gets programmed. It goes into the blood vessel, and now it's programming an immune cell in the blood vessel that has to now escape from that blood vessel in order to get into the nervous system. We can see the escape of those immune cells from blood vessels. You see these cells escaping from the blood vessel to get into the nervous system. To get into the nervous system, it has to be pulled through the walls of the blood vessel. It doesn't just sort of flow through, it gets pulled through the walls by these adhesion molecules that go through and get pulled into the nervous system. Once it gets into the nervous system, it gets exposed to the so-called hormones of the of the nervous system. We call those hormones, if you will, cytokines. And there are other chemicals as well. These cytokines can make the immune reaction worse. We call those pro-inflammatory neurotoxic factors. And that causes destruction. Or they can calm it down. And we call those anti-inflammatory neuroprotective factors. Usually in our system, immune system, these are in balance. But in MS, it seems that there are more of the pro-inflammatory neurotoxic factors. And so that immune cell then gets upregulated, if you will, and becomes more hostile to the environment. So MS is a disease of the immune system. It's also a disease of myelin. And as you well know, myelin is the insulation of the nerves in the brain and spinal cord. And it's also the insulation of the nerves in your arms and legs, but they're different. While myelin is mainly composed of fat and fatty protein, the main ingredient in myelin is cholesterol, so there's some good that cholesterol does as well. But it's different in the brain and spinal cord because the cell that makes myelin in the brain and spinal cord is called the oligodendroglial cell. And you can see that cell pictured here, serving one axon, or maybe two. The cell that makes myelin in the peripheral nervous system is called the Schwann cell. And usually I ask, why do I care? Well, oligocell, Schwann cell. It's because the Schwann cell likes to make myelin. It makes myelin easily. So if you sort of pinch your nerve in your arm and get a radial nerve palsy, a floppy wrist like this, after a few weeks, it starts to work again. Schwann cells put out myelin. Oligocells don't like to do that. So when you lose an oligocell, you lose it forever, as far as we know. And so that myelin is made a little bit differently, and it's very important stuff. And when the myelin degenerates, it leaves the nerve nude. That nerve is called an axon. And when it gets nuded like this, denuded like this, it becomes fragile. And when it becomes fragile, it breaks. So MS is a disease of the immune system. It's a disease of myelin. It's a disease of axons. It may well be a disease of those oligos. When that nerve loses its myelin, it degenerates, it breaks, and when it breaks, it balls up, often looking like that. The green ball is the actual picture of a nerve in the nervous system, broken and balled up. A disease of myelin, axons, nerves, oligos. And here is a video trying to explain what I've just told you in more scientific terms. I think you'll understand it, I hope, with the background I gave you.
When the immune system malfunctions in MS, the result is an attack on the body's own myelin, including its myelin-producing cells, the oligodendrocytes. This attack is thought to be due to a complex interaction among several components of the immune system, including macrophages, cytotoxic T cells, B cells, and various cytokines, such as gamma interferon and interleukins. The immune response is initiated outside of the central nervous system when a self-antigen such as a myelin-type protein, possibly a virus, is phagocytized by a macrophage and subsequently presented to an inducer T cell. The inducer T cell then becomes activated and releases a number of cytokines into the blood, including interferons and interleukins. These cytokines act on other immune system cells, such as B cells and other T cells, to further augment the immune response. Cytokines, such as gamma interferon, cause the endothelial cells lining the blood vessels to express surface adhesion molecules. Once activated, T cells bind to these adhesion molecules and essentially walk through the blood-brain barrier into the CNS. In the central nervous system, activated T cells continue to release pro-inflammatory cytokines locally, and the process repeats itself. Simultaneously, other immune system cells, including B cells and macrophages, also enter the CNS through the blood-brain barrier, which further enhances the local immune response against myelin. B cells produce antibodies that directly attack myelin and oligodendrocytes, while macrophages function within the CNS to phagocytize myelin. The symptoms seen in an acute attack of MS are thought to be due to the problems in nerve conduction caused by axonal demyelination and disruption. The inflammation and edema that can result from breaching the blood-brain barrier are also thought to result in central nervous system damage. Remission of symptoms occurs when inflammation subsides. As time progresses, ion channels redistribute along the axon. In addition, oligodendrocytes proliferate and some remyelination of the axons occurs. Damage to the axons themselves also occurs in MS. Once stripped of their myelin sheaths, the exposed axons are susceptible to further injury from cytokines, complement, and other enzymes, causing them to break and disintegrate. Throughout this time, gliosis is occurring. Gliosis is the process whereby astrocytes proliferate and fill in the damaged areas, producing the characteristic scars of MS plaques. It is thought that the residual deficits patients experience in MS are due to accumulating axon damage, which is irreversible. The chronic active MS plaque shows a gradient of pathological changes. The center of the plaque represents older events, and it is often characterized by many demyelinated axons surrounded by gliosis. Traveling outward toward the border of the plaque, the number of macrophages increases, and there is ongoing demyelination and remyelination. However, in more chronic plaques, there is no evidence of either demyelination or remyelination, and these plaques primarily consist of demyelinated axons surrounded by severe gliosis with axonal degeneration. Axonal transection is a consistent result of demyelination in the brains of patients with MS. This is important because axonal injury can result in permanent neurologic dysfunction. The frequency of transected axons is related to the degree of inflammation within each lesion.
So that gives you a picture of what goes on in multiple sclerosis, but it's more complex than that. When these videos were made, we thought MS was a disease of those T cells that were doing all that action. Now we know that the B cells are involved, and there may be other cells, the microglia may be involved in some way, shape, or form. And so our knowledge is expanding. It gets more confusing a little bit, but in the end, multiple sclerosis means multiple scars, and these scars are in the brain and spinal cord. So multiple sclerosis is a disease of the immune system. It's a disease of myelin. It's a disease of axons. It's a disease of oligos. But more importantly, it's a disease of people. And sometimes we get so hung up on those components to it, we forget that people feel like, I'm wet, I'm tired, and I have MS. They don't feel the best all of the time. Hardened scars. We've learned a lot about who gets multiple sclerosis. So that was a question that was asked of me. Who gets multiple sclerosis? We used to say, and we still do say, that MS is a disease of more women than men, almost 4 to 1. And the data show us that that may be increasing for some reason over time. It used to be 2 to 1, then it was 3 to 1, now we think it's 4 to 1. We used to say that this was a disease of white people. I say we used to say that, but the data show us now that that's not the case. It cuts across all racial groups in significant numbers, so that we can't say that this is a disease of white women anymore. We used to say it was a disease of higher socioeconomic classes. That's not the case either. We used to say rich white women. That's not the case. We used to say that as you moved away from the equator, the amount of MS dramatically increased. So we had large amounts in Minnesota, where I come from. I live in Arizona now, but I practiced in Minnesota. We don't say that anymore because with the travel and with the changes in our environment and with whatever the reason, there's a lot of MS everywhere. And so our philosophies, our thoughts have changed about where MS is and why it's there. As we've gotten more and more knowledge. And that's what's true about science. And I'm just going to take a little sidestep here a little bit. When people are attacking Dr. Fauci for changing this and changing that, they're really full of trash because he is a brilliant man who changes with science. When the science changes, he changes. As we learn more, he changes with it. And that's what we're doing in multiple sclerosis. And you see it in high speed with COVID because we're changing so rapidly as we get more and more knowledge about COVID and how it works. We know where COVID comes from. We don't know how it came there, but we know it comes from a virus. But what causes multiple sclerosis? That was another question that was asked of me. I don't know exactly what causes multiple sclerosis, but there are some islands off the coast of Scotland that may teach us something and have taught us something over many years. These islands are the Shetland and the Orkney Islands. And there are some other islands off the coast of Scotland, right next close to them, called the Faroe Islands. The Shetland and the Orkney Islands are under the auspices of the British Isles. The Faroe Islands are under the auspices of Denmark. Now, during World War II, there was some fear that the Germans were going to march into the Faroe Islands and turn them into a communication depot. The Shetland and the Orkney Islands, for some reason or other, had a large amount of multiple sclerosis. 400, 500 cases per 100,000, a large amount of multiple sclerosis. But the Faroe Islands, for whatever reason, didn't seem to have very much MS, even though they were right adjacent to each other. One under the auspices of Britain, one under the auspices of Denmark. So the British troops marched into the Faroe Islands to protect them. And about 6 months later, there was an outbreak of multiple sclerosis amongst the natives of the Faroe Islands. And they looked around and said, what the heck is going on here? Why are we getting MS when we didn't have it? Oh, those British troops did it. They did it. What did they do? I know what they did. They brought their small dogs in. Those dogs did it because those dogs had a viral disease called distemper. And there was a veterinarian there. And so researchers went in there and said, What's going on? And it was really important that they did that because about 6 months later, it seemed to get less and less multiple sclerosis diagnosed. And so what the heck was going on? So the researchers went in there and they said to the veterinarian, what's going on? He said, yeah, there was a lot of distemper. And then you know what happened? That veterinarian died. He was old and he died. So they really don't know for sure what was happening. But it smelled like a virus. It tasted like a virus. It acted like a virus. Was it a virus? Well, this is the distemper virus. Well, the distemper virus is the kissing cousin of the measles virus. Now, in the 1970s, and I was there in the 1970s, believe it or not, you think I'm young, but I was there in the 1970s. We thought it was the measles. All the literature said it was the measles virus. There were blood tests that said it was the measles virus. You could read, and everything pointed to the measles virus. It was the answer to multiple sclerosis. All we needed to do was get a measles vaccine, and we did. Now we're going to give that measles vaccine. Is that going to cause MS, or is that going to eliminate MS? And there is a measles disease that involves demyelination. It's called subacute sclerosing panencephalitis. Maybe this will do it. So we gave everybody the measles vaccine, and you know what happened because you lived through it too. We got rid of measles, and that was it. No. Then we thought it was the herpes virus. Then we thought it was the chlamydia bacteria. Then we thought every decade has had a virus, and now we're in a different decade, and Dr. Birnbaum's going to teach you about the Epstein-Barr virus, the virus with mononucleosis. That is the virus. It's there. We have all these data and studies. But if I'm in Las Vegas, I'm going to put money that we're going to get an Epstein-Barr vaccine. And I'll bet, I hope I'm wrong, by the way, but I'll bet we'll have MS after that because I just have seen too much of that. Now, the data looks really good. You'll hear about that. But and I'm not a betting man, so I'm not going to lose any money. But I would like to lose money on that bet. MS may be a viral disease, but we know it's a disease of the immune system. We've been looking at that for a long time. We know that's a disease. Where do we get our immune system from? We get it from mom and dad. The likelihood of getting MS just out of the air, if you don't have any MS in your family, is about 0.2%, 2 out of 100. If your mother or father has MS, and if you're a woman, the likelihood of you getting MS is 4%. My mother had MS. The likelihood, if I'm an only child, but if I had a sister, it would be 4%. That's a small amount, 96% chance of not getting MS, but it's a lot greater than 0.2%. If you're a man, the likelihood of you getting MS is around 2%. That's really small, but it's a lot greater than 0.2%. So the question was asked, what about identical twins? That was asked by one of you out here some time ago. If your identical twin happens to have MS, the likelihood of you getting MS is 30%. 30%. That's not small. Now that tells us you don't inherit the disease, because if you did inherit the disease, it would be 100%. But it's telling us that there's a genetic aspect to multiple sclerosis. Now the human chromosome has been mapped out for years and years, and just this past few months, they've announced they've got it finally fully mapped out, but they had it pretty much mapped out before. And so researchers have studied people who have MS in their families and things and see, are there some genetic chromosomal things that look the same within parts of the chromosome called single nucleotide peptides, SNPs. And they found several hundred SNPs that are correlated with the disease multiple sclerosis. So we're learning more. There's a future there. It's not prime time yet, but it's getting there. We're getting there. But what about trauma as a cause of multiple sclerosis? When I was practicing, I'm retired, as you can imagine, but when I was practicing, I often saw people who had some kind of trauma. Bumped fender, sometimes major trauma, and then they got MS shortly thereafter, and they really wanted to tie it together because we like to have cause and effect. So we've looked at this over and over and over again, and we cannot find that correlates with trauma. I can imagine a real severe trauma breaking down that blood-brain barrier, causing all kinds of problems in the brain and spinal cord if you were paraplegic or something of that nature from the trauma. But that's not the typical circumstance. So we don't think trauma is the cause of multiple sclerosis. the question was asked, well, what about life expectancy in multiple sclerosis? And so we can do those studies, and they've been done over and over again. If we lump all MS together, severe MS, mild MS, what have you, the lifespan of an individual with MS is a few years less than the normal lifespan, but not significantly so, depending on the circumstances of that individual. I was asked the question, what is considered an exacerbation? Which brings us to diagnosing multiple sclerosis. I was trained by the father of American neurology. His name was A.B. Baker. And Dr. Baker was a clinician and a teacher, and he used to say diagnosing multiple sclerosis was easy. Easy. I was trained by him in the 1970s, early 1970s, late 1960s and 70s as a student and resident. And we didn't have MRIs, and we didn't have all this fancy spinal fluid stuff, but we still had to diagnose multiple sclerosis. And he said, well, if you have somebody who's between the ages of 15 and 55, a young person, if you have somebody who's had fluctuations, exacerbations, flare-ups of nervous system, central nervous system symptoms, exacerbations followed by a quiet time, remissions and exacerbations, that's the second thing. And if you have somebody who has multiple abnormalities in their central nervous system, when we go to examine them, we're doing the reflexes and strength and coordination. If we find multiple abnormalities, that's multiple sclerosis 99 times out of 100. You don't need fancy diagnostic tests, and you've got the diagnosis. And he was right for the most part. Not entirely, but for the most part. That meant you couldn't make the diagnosis with the first attack. It meant you couldn't make the diagnosis with a normal neurologic examination. So if you had an optic neuritis, you went to see the neurologist, that's one spot, one attack. The neurologist shouldn't say, clinically, you've got multiple sclerosis from that picture. You had to wait, and so that's where this is hard to diagnose thing came. And then the neurologist didn't like to diagnose things without somebody saying it for them. So they felt insecure. So they would say, this is demyelinating disease, or this is inflammation, or whatever. But then along came the magnetic resonance imaging machine. And that was in the 80s and late 80s. And we began to be able to look into the nervous system and actually see the spots that we could see with multiple sclerosis. So somebody asked the question, what exactly is a black hole? So here's a picture of an MRI, and you can see the inflammatory white spots in the brain, these white spots here. And then we learned that we could give a contrast, a magnetic contrast material, and you could see the spots fill up that were new lesions that were there earlier than 6 weeks. They would contrast enhance for 6 weeks, and then they would become not contrast enhancing. So we could date some of the lesions. And we learned how to do it differently. And then once those tissues actually got damaged and lost, like we showed in the video and talked about, the axons broke down and degenerated, we get black holes that you can actually see in the MRI, black holes. We don't like black holes. It causes the brain to shrink, and it's not a good thing because we can't get anything back. We can see these in the spinal cord. You can see the inflammation as well. So the MRI made a big change. Now, over the years, we've learned how to do the MRI better and better and better. And so the consortium has been a leader in trying to develop, consortium of multiple sclerosis centers that we're here for, has been a leader in trying to develop protocols to give us the best results from MRIs. And this just came out in 2021. And we were going to put these on the table. I don't know if they ended up on the table or not, but they're available from the CMSC to take to your neurologist so that they know the best way to get the best material out of your MRI from the radiologist. So diagnosing multiple sclerosis got easier with our MRIs. And along the way before the MRIs, we got evoked potentials. This measured the time it takes for an electrical impulse to go from a TV screen to the back of your brain where we see it. We can get an electrical charge that shows us how fast it's moving. And if it's delayed and short-circuiting, we can see that. And if somebody has weakness in a leg and then they have a short-circuiting in this system, that gives us 2 spots without any fancy examination abnormalities. So we had evoked potentials. And of course, we have spinal fluid that we can look at. I can do a spinal tap blindfolded, I think. I haven't done one for a while, but I still think I could take a needle and throw it across the hall and it just goes right in. We got to do it. But you take that fluid and we run it through an electrophoresis machine and we can see some banding that tells us that this person may have multiple sclerosis. It's not exact. We have to look at the blood and make sure it's not there as well. But we can do that type of thing. We can also now look at the retina, the retinal fiber layer with a fancy test called optical coherence tomography. It's a machine, painless. I had it myself because I'm getting old and they look at your optic nerves that way without having multiple sclerosis. And it's an easy test to do and you get a readout and it gives us some idea of how things are looking in the eye, which helps us make the diagnosis of multiple sclerosis. And I get asked all the time, and you folks asked as well, what about Lyme disease? I don't know why everybody wants Lyme disease, but they want Lyme disease. It comes from a deer tick. It's a rickettsia. It's not a fun thing to have, but typically it doesn't get involved in the central nervous system. But if you live in an area where there are deers and wild animal like that, we want to make sure that MS is not just, that what we're thinking of is not just MS. We want to rule out other things that may look like MS, Lyme disease and other diseases that look like MS, neuromyelitis optica, which some of the folks here are involved with, our sponsors. We want to make sure we're not dealing with a different disease that mimics MS, and so we do tests to look at that, even though the likelihood is we're not going to find that. And we can do those tests. We are in the era of exploding knowledge. We've been in that era now for 30 years. It's dramatic, the changes I've seen in multiple sclerosis. The reason we have seen these changes is because we learned how to study multiple sclerosis. And it was really important to study it properly because what we were doing before was taking everybody with multiple sclerosis. People were in wheelchairs and people were walking. And we threw them in the same pot and did a study. And nothing worked. Nothing worked. We had to understand that the studies had to be done properly, randomized, double-blind, placebo-controlled clinical trials. By that I mean that the people didn't know that they were taking real drug or not, and the investigator didn't know whether it was real drug or not because the placebo effect in multiple sclerosis is 65%. 65% of the time, no matter what I give you for your multiple sclerosis, you'll get better. For a while. But just for a while. And then it all comes back. That's dramatic. That's dramatic, but we have to understand that. That's true of a lot of diseases, not just multiple sclerosis. So that placebo effect means that we got the craziest treatments for multiple sclerosis. Pregnant cow's milk, cobra venom, bee sting therapy, all kinds of funny treatments, operating on veins, crazy things. Even in the present, we see. I go on Facebook and I see these crazy treatments that people are selling. And they can sell them because they'll get somebody to say, I got better for a while. And then they quietly go away. So we have to do those studies. Now, we can't do them the same way we did them before because we have legitimate treatments now. So you can't give somebody a placebo for their MS when you have a real treatment that works. You have to do a comparator trial. You have to compare it against something else in order to do it properly. And then we had to divide people up into how they look. So we developed a classification for multiple sclerosis. And we knew that 80% of people started their journey with MS with a fluctuating course. We called that relapsing remitting multiple sclerosis, or relapsing multiple sclerosis. 80% did that. Over half of them along the way stopped having those relapses and slowly got worse. We just changed the name, called that secondary progressive multiple sclerosis. And 10% of the people got worse from the get-go. We called that primary progressive. 5% progressed and then relapsed. We called that progressive relapsing, and then we realized that maybe these two are the same disease, so we combined them. So now we talk about relapsing multiple sclerosis, secondary progressive multiple sclerosis, and primary progressive. Primary progressive gets worse from the get-go. So then when we did that, we could divide people up like that and study them, the population separately. And that's when we started to get drugs. We started with studying relapsing multiple sclerosis, and now we have 25 drugs to treat relapsing forms of multiple sclerosis. We'll talk more about them in a moment. Suffice it to say, that was an important thing that we did, to divide people up into categories. But what about the person who has their first attack? And yet if the attack looks like MS, but they need to have that second attack to make the diagnosis. But then we have the MRI, and the MRI can help us. We call that first attack a clinically isolated syndrome, but the MRI often will give us information that allows us to see they've had attacks before, they didn't even know it. So we don't see this too much anymore because most of these people we can actually diagnose with as having relapsing multiple sclerosis. But now we're faced with the conundrum. Somebody has been diagnosed with secondary progressive multiple sclerosis, let's say. Secondary progressive multiple sclerosis. And then year after year, they come into the office and they haven't progressed. They're disabled, but they're not getting worse. So how do we call that progressive? So we have to attach an adjective to it. Are they active or are they stable? And that's really important because people get diagnosed with relapsing MS, and then they get put on a drug. And then they're good. What do you call them? Relapsing MS? Yes, but they're not relapsing. And so it's important to keep track of what people are and get them in the appropriate slots so they can take the appropriate medication studies. Does secondary progressive MS turn into primary progressive MS? That was asked of me. And you know, but sometimes primary progressive MS does turn into secondary progressive MS, strangely, because somebody with primary progressive MS that gets worse from the get-go. They get MS and get worse from the get-go. Goes into the doctor, and the doctor says, well, you're primary progressive MS. By the way, when you were young, did you ever have any problems with your eye? And they say, oh, you know, right, the doctor said I had an optic neuritis when I was 16. Well, suddenly they had a relapse. Now they're not primary progressive. Now they're secondary progressive MS. We just changed the names. They're probably the same disease, but are they? They may not be. The average age of onset of somebody with relapsing remitting secondary progressive MS is 30. That's the average age of onset. It's not the median in the community, but the average age of onset. It's 50 for primary progressive MS. It's a 4-to-1 ratio for relapsing remitting secondary progressive male to female. It's 1-to-1 in primary progressive. A lot more spinal cord involvement in primary progressive. So there may be different diseases, but they look alike underneath the microscope. This is what it looks like in the community. The big blue is, or purple-like color there is relapsing remitting and secondary progressive, and the rest primary progressive. Well, managing multiple sclerosis is about 3 things. It's about disease management, symptom management, and person management. And now we can do things for all 3. We can look at the disease, and we have drugs. Lots and lots of drugs. We had none for much of my career. Lots of drugs. And they're all immune system drugs. They all affect the immune system somewhat differently than others. Some are injectable, some are oral, some are infused. It doesn't matter what the route is. The idea is to get it in there and get the work going. Just because it's IV doesn't make it stronger than oral. It's just a matter of how it's absorbed and get into the system to do that. We have lots of these. And you know, I keep hearing about these high-efficacy drugs. The newer drugs are high-efficacy drugs. I hate that. I can't do anything about it. It's what it is. Because if you're on a, quote, low-efficacy drug and it's working, it's not low efficacy to you. It's high efficacy to you. If you're on the oldest drug that we have, beta-seron, and it's working, that is, you're not having relapses, you're not having new MRI attacks, your disease isn't progressing, it's high efficacy for you, but there's no question that there are stronger drugs. We have drugs that are clearly stronger, and there's a debate within our grouping as to whether we should start with stronger or start with weaker, or how we should do it, or whether we start and give stronger first and then come back with weaker. That's science will work that out eventually, but are the players really all alike? I've run out of green pills, so I suggest you take a yellow one and a blue one together. Some practitioners act like they're all alike. I hope he doesn't realize these pills are placebos. I hope he doesn't realize this money is counterfeit. We may even mistrust the doctor a little bit. Are they being paid off to use this drug or that drug or whatever it is? It's which one should you use and when? And I believe, quite frankly, that this is a medical decision. A lot of doctors want to put it on you folks. Choose a drug. I don't like that idea because who has the education? I don't care how much you're studying, but really the education to make the proper choice. But if you do choose it and you choose wrong, it's easy for the doctor to say, gee, you chose wrong, rather than saying, I chose wrong for you. But the fact of the matter is you have to take the drug. So if you don't like it and you don't take it, that's not good. So we have to make the choice together. That means we have to understand why we're choosing a drug, make sure that it's one that you will tolerate, that you will take, that will work for you. But one of the things that's gotten lost over the years, and I think it's really important to know, is that before we had drugs, we learned a lot about MS, and then we forgot it. People like Dr. Birnbaum and myself, we were around and saw that there were a third of people who had MS that ended up in nursing homes with no drugs available to treat the disease. A third. There was another third of people in the community that ended up with severe disability but ended up in the community. They stayed at home. They didn't end up in nursing. That means 2/3 of people with MS had significant disability. But there was another third. And that other third, for whatever reason, didn't get that disabled. They didn't get that disabled. And we call that benign multiple sclerosis. And a lot of doctors didn't want to admit to that. Oh, there's no such thing as benign. I saw it. I saw it. And then every time it was studied formally, they saw that there were 20% of people in the community had MS for 30, 40 years that had not gotten worse. But the only thing you had to do to find out whether you were benign or not is wait 30, 40 years. Because we had no way to predict who was going to get worse. We knew who was going to get worse. We couldn't tell who was going to stay benign. Sometimes we knew people were not going to do well by their symptoms, but we knew that we needed to treat people early because we couldn't tell. So we wanted to treat people early, even though we knew that maybe we're over-treating 10, 20% of the people we couldn't predict. It's a risk-benefit ratio. So what really works? I like practical approaches. Tom Kelly was the manager of the Minnesota Twins for 2 World Series championships, and he used to say, put a player in a position in which they can succeed. We want to put people in a position in which they can succeed. To prevent a heart attack, you take 1 aspirin every day. You take it out for a jog, then take it to the gym, then take it for a bike ride. We want practical, successful solutions. We don't know who's going to do well, but we can tell when people are not going to do well. If they're having frequent attacks, if their MRIs look terrible, if they have spasticity and ataxia, clumsiness and tremor, if they're having cognitive difficulties, if they're getting worse in front of their eyes, if their spinal cord is involved a lot, we're going to be more aggressive. We're going to be more aggressive, and we're going to suppress that immune system more with stronger drugs. But what is the effect of that down the road? So far, so good. But when PML came out, that viral disease, progressive multifocal leukoencephalopathy, with one of the drugs that was more efficacious, if you will, supposedly, I began to worry, and I still worry. It's a risk-benefit ratio we have to look at and pay attention to. Now, it may not happen, but I worry about it. I don't worry about how we give the drug. Which one is the best for me? And the answer is you try to find the right treatment for the right person at the right time. So you look at how active is the disease? What is your risk tolerance to things? Are you willing to take chances or not take chances? What's the risk tolerance of the physician? Are there personal issues? Is the insurance company going to pay for one and not for the other? We got to be practical about it as well. So you look at all those things, and then you'd be prepared to be wrong. And if you're wrong, you change. Question was asked, are there therapies for secondary progressive MS? We're working on it hard. But you know, everybody with secondary progressive MS has some inflammatory component to it. So maybe the drugs will work even if they haven't worked in the aggregate. So most of us feel like, let's try them and see what happens. And if it doesn't work, we'll stop it and try something else. So we do immune management, even though we don't have a lot of good data for it. But we can manage the symptoms, and we can manage the person. And so we developed an approach in Minneapolis where people with significant MS would come, these are significant MS, would come for once a week for the whole day for maintenance rehabilitation. And we learned that across the board, the answer to disability is mobility. The answer to disability is mobility. Say it with me. The answer to disability is mobility. One more time. The answer to disability is mobility. You have to stay mobile. You have to keep functioning. This is non-specific. It's long-term. It's more general. What we're trying to do is maintaining function even if there's disability occurring. We maintain function despite progression. What about stopping the medication when you get older? Well, there are a number of people whose immune systems poop out when they get older. The term immunosenescence. You've heard that term with COVID. Immunosenescence. That's why older people get COVID. Easier. That's terrible. They get it easier than younger people because their immune systems are pooping out, if you will. That's bad with COVID. It might be good with MS. They poop out, and then maybe you can be taken off, but that's something you have to look at with your doctor. There are studies that show that. Dr. Birnbaum did a study that showed it, that if your MRIs are stable, if you're stable, you may be able to get off that medication, but that's a personal choice you have to work with. What about diet and smoking? Well, we're going to hear about diet. We know that smoking makes everything worse. And it makes your symptoms of MS worse. They say it makes you easier to get MS. Or I don't know if I buy any of that because my mother smoked a lot, and now nobody smokes, and MS hasn't gone away. So I can't buy that smoking is, but it's not good for anybody. Question was asked, why is it taking so long to find a cure? It's because it's so complex. It's so difficult. And what should people know about the COVID vaccine? Well, I'm going to let Dr. Birnbaum tackle that, because I want to spend a couple of moments and talk about symptomatic management. This prayer says, God grant me the courage to change the things I can change, the serenity to accept those I cannot change, and the wisdom to know the difference. But God grant me the courage not to give up, even though it may appear to be hopeless. This is the prayer of MS management. The answer to disability is mobility, and there's the prayer I got behind on my slides there. I wrote a book, Managing the Symptoms of Multiple Sclerosis. It's had 6 editions. You see that on the left. It's a little bit dated, still available. The management hasn't changed that much over the years since that book came out a few years ago. The German edition's on the right side there. We're going to talk about spasticity for a moment. Very common symptom, stiffness in multiple sclerosis. First thing we do is see if there's any pain in the body. If you have a broken hip or if you have arthritis or something, we want to manage that because that will make the pain, the spasticity worse. And then we begin an exercise program. And Brian will talk to you about that. I'm not going to spend a lot of time on that. Suffice it to say, we want people to stretch and do well with their exercises to eliminate the spasticity as best as possible. If you have a dog, you understand this slide. If you have MS, you understand this slide. If you have a dog and MS, you really do because spasms occur. We have lots of drugs that we can use, and we've learned how to use them well. And if the drugs don't work, we have procedures that we can do. We can inject Botox. Those muscles look beautiful after we do it. We can put in a baclofen pump. We can manage that stiffness. Fatigue is the single most common and the single most disabling symptom in multiple sclerosis. And that's because we have 5 different kinds of fatigue. We have normal fatigue. You work hard, you get tired. We have short-circuiting fatigue. You come walking in here to this hotel to get to this room, start out walking pretty well, but by the time you get here, you're having a hard time with that. You can see that nerve short-circuiting. We have deconditioning fatigue if you're out of shape. We have the fatigue that occurs with depression, and Fred's going to talk about that. Dr. Foley's going to talk about that. We have the fatigue that occurs in MS very frequently, an overwhelming tiredness that hits people for no particular reason. That's the single most common one. The short-circuiting fatigue, we have medications for. Drugs like Ampera will help in certain cases where the nerve is able to use the medication. We can do exercise for deconditioning. We have to treat depression very aggressively. We'll say a few words about that in a moment. And there are drugs for the lassitude, that overwhelming tiredness as well. Occupational therapists help us by organizing the day and planning it appropriately. If you have depression, I'm going to let Dr. Foley deal with that, but what I want to say is you can have depression because things are bad around you. No money, bad marriage, kids, whatever it happens to be. But you can also have depression because of demyelination, neurochemical changes. While counseling helps both of those, we need medication sometimes to change the neurochemistry. And as you're out and about, you look for signs like this. Because the bladder is a real problem in multiple sclerosis. We have small bladders that don't store. We have big bladders that don't empty. And they give you the same symptoms: urgency, frequency, hesitancy sometimes. Same symptoms. But they're different, and they're treated differently. So we need to do an analysis to find out what kind of a bladder you have and then treat it appropriately. We have bladders that want to empty, but the sphincter, the opening, closes at the same time. We treat that differently. If people are getting up at night, we treat that differently. I want to talk to you some new knowledge about bladders. I'm going to talk to you about sitting. I'm going to teach you something new, something you probably didn't know. Men, they stand to pee. Did you know that? Did you know that? Women, they sit to pee. I thought I'd show you a picture of my bathroom at home. Now, my wife is sitting over here, and I can hear her right now because this happens about once a month. Randy, you left the toilet seat up. Well, my wife is an interior designer. She wants the toilet seat down, but she's an interior designer, so she redesigned our bathroom just for me. You know, men have to learn to sit to pee. Doesn't come naturally. We have to practice it. So we work on it quite a lot. Sometimes we have to deal with bowel problems in multiple sclerosis. Sometimes we have to get a stool sample. Well, maybe not that kind of a stool sample. Yes, that was very loud, Mr. Trainer, but I said I wanted to hear your heart. So we have to get those bowels moving. We don't want to be dehydrated first. You hydrate. We want to get you on a regular basis. We want you to have a bowel movement right after a meal because you have a gastrocolic reflex about 30 minutes after a meal that allows you to have a bowel movement easier. I think you ate a few minutes ago, so don't feel shy. I'm sorry, Mr. Jones, but your HMO does not pay for enemas. I'm going to have to slap the shit out of you. And sometimes our fiber, we get people on fiber, it gets too aggressive, and we get people eating too much fiber. What about trigeminal neuralgia, lancinating facial pain? It's severe, it's miserable, and that brings us to pain in multiple sclerosis. It's a burning, irritative nerve pain. It's not just pain, and so pain medicines don't work. We have to use specialized medicines for that. We have to eliminate orthopedic problems. Cognition is a problem in multiple sclerosis. We're going to hear more about that today, too. And we have to keep active and watch your medications, watch for depression, and make adaptations. Speech pathologists help us with that as well. Somebody said, what about adjusting to life after receiving Social Security disability? And I think I can speak to that because I'm retired. And I've learned over the years from my patients and from my own personal experience now as retired, you have to have organization to your life when you're retired. You have to have some reason to get up in the morning. So I get up 4 days a week for a coffee group at 7 a.m. in the morning, and we sit around and talk for an hour. Just a bunch of guys just talking about life. And then I go and exercise after that for another hour, and you get organization to your work. I'm fortunate enough I can go and golf 2 days a week, and so we get some planning so that there's some reason to keep on going. Well, I'm going to end now with this serenity prayer. God, grant me the serenity to accept the people I cannot change, the courage to change the one I can, and the wisdom to know it's me. Thank you. Now, at this time, I'd like to welcome Alexa from Catamount Medical Education, who have done a great job organizing this, up here for some activity.
Thank you, Dr. Shapiro. Hi, everybody. I'm Alexa Lassick with Catamount Medical Education, and I will be leading an interactivity today. Hopefully, everybody can join in and have a little bit of fun. So we have a couple of options for you. If you're in person, we have the cards in front of you. You will see it labeled 1, 2, and 3. And you can also participate by using your smartphone. And I'll go over those instructions. If you are live streaming, you can participate using your smartphone as well. So on the cards in front of you, you'll also see in the center of the table, if you would like to participate using your smartphone, you just open up a regular text messaging box, and you're going to put into the phone number space the number 22333. And then in the body of the text message, you're going to enter MSM22. And if you don't want to bother with that at all and you're in person, you're welcome to use the cards for the whole activity. You'll know you entered the activity when you receive a message that says you've joined Jennifer Green's session, MSM22. So you're going to go ahead and click on that link there. And it will bring you to the main page where you can log in using the polleverywhere.com. So you're going to scroll down and click on the I'm a Participant button. And you're going to, again, enter that MS22 as the username and click Join. This will bring you to the activity page, and it might pop up a button that says to enter a username. You can go ahead and skip that. You don't have to enter a username. When you're all signed up, it will say online access, and as soon as the activity begins, you will see it here. Now let's give it a try. For the next few minutes, we'll be asking you to follow along. For the first 2 questions, you'll just be typing in a single word into the online activity page, and then you'll see it appear here on the screen. You may have typed your name into the space where it says to enter the session, which is the MSM22. That has happened before. Because it does look like people's words are popping up here on the screen, which is great. And if you do have trouble accessing, I have a couple words here. Feel welcome to hold up one of your colorful papers. For 1, the pink card if you're feeling positive. 2, the yellow card if you're feeling excited, or 3, the green card if you're feeling interested. This way you can participate that way as well. That's excellent. A mix of emotions is always okay too, right? Wonderful, we have someone that's interested. That's excellent. You can see up here the words popping up. The words that are larger means more people are choosing those. Impressed, that's a great one. Inspired, that's... All right, so we're going to move on to the next question here. So what is something that you are looking forward to this year? And if you'd like to use those cards, I have 1 as a wedding, if anybody has a wedding, 2, an anniversary, or 3, a birthday. Camping. Vacation, camping, research, those are all exciting. Oh, a lot of vacation. All right, well, I love these, and the more people that choose the word, the larger it gets. So it looks like a lot of people are going on vacation, which is awesome. All right, for the next few questions, I'll be asking some multiple choice questions, and you can either hold up the colored card to answer or select the picture on your device in front of you. And since we're in Washington, D.C., and there's so many amazing sites in the city, we're going to play a game to see how you locals know the area. And if you're not from here, this is just a little fun trivia. So the first one here, at the time it was built in the 1800s. It was one of the largest office buildings in the world. So the first picture is the U.S. National Bank, number 2 is the White House, and number 3 is the U.S. Treasury Building. It looks like so far most people are choosing 3, the U.S. Treasury Building, on the screen here. I thought this was a tricky one, but I'm also not from around here. All right, excellent. Well, it does look like most people got the answer correct here. The answer is 3, U.S. Treasury Building. And this building actually burned down and was rebuilt several times during the 1800s. It ultimately was one of the largest office buildings of its time. All right, the next question. As you may or may not know, Washington, D.C.'s streets are named using the alphabet in order. One of these letters is not featured on a street sign. So which street name is missing from every quadrant in Washington, D.C.? Is it R Street, 2G Street, or 3J Street? Looks like most people are holding up a green 3 in here. All right, well, it looks like most people know Washington, D.C.'s history from being around the area. That's wonderful. The correct answer is 3J Street. The streets ascend east to west alphabetically, A through W, skipping J. And this is because the letter J looked too much like the letter I. So Pierre L'Enfant omitted J Street in D.C. And just another fun fact, a J-related trivia, in order to avoid the same letter confusion, there is no Company J in the U.S. Army Battalion, which I found very interesting. So for these next few questions, we'll be asking you to choose the statement on the slide that is false. So this is called 2 truths and a lie. Choose the statement that is false. 1, Darth Vader adorns the National Cathedral. 2, every president has lived and worked in the White House. And 3, every road in the city leads to the Capitol building. So remember, we're looking for the false statement here. Looks like the participants online are catching on to me. All right, wonderful. Well, the correct answer is number 2. Every president has lived and worked in the White House. That is actually false. John Adams was the first president to live in the White House. It was built after George Washington had passed away. And the National Cathedral does, in fact, have Darth Vader. He can be seen on the Northwest Tower if you bring binoculars. All right. One last question here. Choose the statement that is false. The White House movie theater was originally a coat room. Woodrow Wilson is the only president buried in Washington, D.C., and Presidents Hoover and Adams both kept snakes as pets in the White House. This one was by far my favorite. Seeing some yellow 2s in the audience here. See 1, 3 back there. Looks like we're pretty evenly tied online as well. Some more 2s in the audience. All right, well, actually, number 3 is false. Presidents Hoover and Adams did not have pet snakes. They actually, in fact, had pet alligators in the White House. Woodrow Wilson is, in fact, the only president buried in Washington, D.C. He is buried in the Washington National Cathedral. Well, thank you, everybody, so much for playing some trivia with me. And we hope you enjoyed our fun facts on Washington, D.C. At this time, I would like to welcome Dr. Gary Birnbaum for his presentation.
Hi. Thank you for asking me to speak with you this afternoon. I'll be talking about MS Research Update. I have a website which also deals with MS Research Update. I think it's in your handout. You can see that. And I have a Twitter account, which I don't use very much except to notify people after I posted something on my website. So I will be talking with you about some very new and exciting things which have really changed in the large number of years that I've been involved in the care of MS patients. So, let's see, this is an outline of my talk. I'll be talking about why does MS happen? Is it because of the immune system, or is it because the brain isn't as it should be in persons with MS? Talking something about viruses in MS. Of course, one has to talk about MS and the COVID-19 pandemic. I'll be talking about that. And finally, some exciting new data on systems medicine, a concept that has been around for a while but has not been particularly utilized in the field of medicine. But I think that will have enormous applications in terms of MS understanding and in terms of the therapy of persons with MS. So, first of all, let me ask the question, are the brains of MS persons different? Is there something about the physiology of an MS brain that might be very important in terms of actually triggering the disease process? And it was the work originally of John Prineus, who is now, I believe, in Australia, who was able to look at autopsy specimens of young people who were very early in the course of their disease. I think they were killed in car accidents or other causes of death. And what he found was that in these individuals, very early in the course of their disease, there was very little in the way of inflammation. And what he predominantly found was a dying back or a sickness of cells that make myelin, the oligodendrocytes. So he hypothesized, well, gee, maybe the initiating event of the disease is not inflammation, but perhaps an alteration in the function of the brain. And this was a very disputed finding, of course. And then several decades later, a physician, Daniel Factor, and his colleagues looked at the genes of oligodendrocytes in persons with MS, and by golly, these genes were not functioning normally. They were producing and synthesizing proteins in an abnormal fashion without any evidence of inflammation. So this was a genetic abnormality in myelin-producing cells that appear to be unique to persons with MS. So again, an indication that perhaps it was the brain of people with MS that had a very important role to play in the disease process. An interesting observation, sort of indirect, is the work of Dr. Cairns and his colleagues. He looked at MRI scans, and he found this funny-looking white matter in the MRI scans of some individuals, and when they were looked at under the microscope, there was no inflammation in those areas. But if you followed these scans over a period of time, these were the areas that became acutely inflamed. So something preceded acute inflammation that didn't quite look right on MRI scans, again, supporting the observation that perhaps the brains of people with MS predisposed them to a certain extent to an immune attack. And then some very recent data that hasn't even been published yet is the work of Dr. Harrod and his colleagues. He was a spokesman for this international consortium of scientists who looked at the genes of people with MS, and he did a very exciting thing. He looked at the genes that were involved in susceptibility to the disease. What genes predisposed a person for the development of MS? And this has been fairly well examined, and it seems that the genes, which there are over 200 now, that are involved in susceptibility, are genes involving the immune system. So clearly the immune system has a major role to play. But then he looked at genes involved in disease severity. As you know, MS is a very variable disease. Some people having severe disability within a few years, and some people actually having very minor disability over a period of decades. And he analyzed genes associated with the severity of the disease, and by golly, they were different than genes involved in susceptibility. They were genes associated with tissues of the central nervous system, in particular, certain foci of genes. So clearly, the brains of people with MS are active participants in the disease process. And what does this actually mean? Well, as I said, if the central nervous systems of persons with MS are indeed different, how could this have an effect? Well, if you have an abnormal synthesis of proteins, if what you're making in the brain isn't as it should be, and the immune system recognizes this, this could be actually the initiating event in the disease process. Or perhaps these alterations in the brain increase susceptibility to viral infection, as we'll talk about, a particular Epstein-Barr virus. Or perhaps it reduces the ability of the brain to heal itself. Or all three of the above. We don't know. This is an area that is significantly under-investigated. So if we're really going to do something in terms of curing MS, it's obvious the immune system is insufficient in terms of providing a cure for MS. We have to learn what is it that's changed in the brains of persons with MS. What is the change, and how does it interact with and participate in the disease process? Very exciting. This has, as I said, been under-investigated, but is going to be an area of intense research, I would say, in the next several decades. So what about viruses? Viruses, all of us have a bunch of viruses inside of us. As you know, there are two stages to a viral infection. You have the active infection, and then a virus can persist in your tissues. It becomes a latent infection. And we've all had reactivation of viruses. How many of you have had fever blisters? I know I certainly have had. Shingles is another one, the chickenpox virus, a very unpleasant reactivation of the virus. Epstein-Barr virus, which is extremely common, as I'll be talking about. It can cause infectious mono, certain types of cancer, extremely rare, but it can happen. You have cytomegalovirus. So that viruses are within us, they're there, they hang out, and they can become reactivated under times of different stress. But let's talk about Epstein-Barr virus, because that seems to be a hot topic at the moment. Extremely common virus, extremely common. This afternoon, actually this morning, I heard one of the leading scientific investigators in Epstein-Barr virus speaking, and by the time you're a teenager, 95% of individuals have been exposed to Epstein-Barr virus. How can we tell? We look at their antibodies in their blood. That's how we are able to determine that they've been exposed. Most of these individuals have no symptoms from the disease, or from the infection, I should say. And the virus, we know, infects B cells. Not all B cells, a subpopulation of B cells. It affects them permanently until the B cell dies, and then the virus is released and goes to other B cells. And as you know, B cells make antibodies. And of course, after you're infected with Epstein-Barr virus, your immune system responds. And it responds to a bunch of different proteins, but the main proteins that seem to be stimulating the immune system, and this is important because people with MS have more of a response to these particular proteins, are the EBNA virus, Epstein-Barr virus nuclear antigen virus, for those of you that are familiar with that. And there are two of them, EBNA1 and EBNA2. So how long have we known that Epstein-Barr virus has something to do with MS? Well, it turns out we've known this for a long time. But the proof that it has anything meaningful to do with the disease is really fairly recent. So we know that antibodies to Epstein-Barr virus are higher in persons with MS, in particular to EBNA2. We know that the virus particularly infects B cells latently for the long term, and that they are found in the central nervous system of persons with MS. In some instances even, we find these immune cells called T cells, which are able to kill virus-infected cells, and they seem to be higher in persons with MS. People have looked for the virus in the brains of people with MS, and the findings have been controversial. Some people have found the virus in the brains, other people have not, so that's uncertain. But certainly B cells containing the virus are present in the central nervous system. So there was this very exciting paper, I'm sure you've read about it in the New York Times, Washington Post, Wall Street Journal, which is where I get all of my scientific information from, by the way. And these are the most persuasive data yet, that Epstein-Barr virus has a significant role to play in the disease. And it's the work of Dr. Bjornevik and his co-workers, and they utilized a unique resource, which is the Department of Defense Serum Repository. Now, those of you who have been in the military know that you're bled at the time of entry into the service, in more ways than one, I'm sure. And they save your blood, and every 2 years, it says here that you're bled actually twice a year, but you're not. It's only every 2 years. You're again bled, and your serum is then saved. So they have over 60 million samples of serum in this serum suppository. And those are the pictures there. You can see them, boxes and boxes. And all military personnel have that, and they're stored for decades. And so what these investigators did, they looked at persons with MS that were diagnosed while in the military. If you're diagnosed while you're in the military with MS, it's a disabling disease, and you're pretty much automatically discharged. So the diagnosis has to be established with certainty. You have multiple physicians who have to affirm the diagnosis. It's not a diagnosis that's made very, very lightly or easily. And they found 801 people who were diagnosed with MS while in the service. And then they looked at those individuals who had antibodies to Epstein-Barr virus. As expected, the majority, overwhelming majority, had been exposed to the virus, but they found 35 individuals who were Epstein-Barr virus antibody negative at entry into the service, and at some point later on had the diagnosis of MS made. And they went and they looked at their serum samples over the period of time. They needed at least 3 different samples. And what they found was that 5 to 10 years before the diagnosis of MS was made, 97% of these individuals, 34 of the 35 individuals, had become infected with Epstein-Barr virus. If they looked at a control group of people who were Epstein-Barr virus antibody negative but did not develop MS, only 57% of them converted. So if you converted to Epstein-Barr virus positivity, you had a 32-fold increase in your risk of developing MS. So then they wanted to see, well, you know, how does infection with Epstein-Barr virus affect the central nervous system? So again, they looked at serum samples at the time of entry into the military, at varying periods after being in the military, and at the time of diagnosis. And they measured a protein called neurofilament light chains. This is a protein that's released from axons, as you heard from Dr. Shapiro, a protein released from axons that indicates that there's some damage to the central nervous system. And what they found was that at the time of entry into the service, their serum neurofilament light chain levels were normal, but within 2 to 3 years after infection with Epstein-Barr virus, in the absence of a diagnosis of MS at that time, they showed evidence of central nervous system damage as manifested by an elevation of these neurofilament light chains. So the infection was causing central nervous system injury in the absence of any particular symptoms at that time. So what do these data mean? Well, becoming infected with Epstein-Barr virus increased the risk of developing MS, as I said, 32-fold. Infection with the Epstein-Barr virus in persons who go on to develop MS, not other people, as I'll show you the data, is associated with a brain injury. So they looked at other viruses too. Well, perhaps this is just a non-specific phenomenon of any virus infection. They looked at other viruses, actually hundreds of them. The only virus that seemed to have this association with risk for developing MS, indeed, was the Epstein-Barr virus. So these are some of the data. Here you can see that. All of the dots, and I don't know how well you can see it, but they're green dots and blue dots. The green dots indicate your Epstein-Barr virus antibody negative. When you turn from green to blue, that's the time that you have been exposed to Epstein-Barr virus. And as you can see, the blue dots occurred oftentimes 5 to 10 years before the diagnosis of MS was made. So clearly, something about Epstein-Barr virus infection precipitated the development of the disease years later. There's only one individual who had green dots all the way along who was diagnosed with MS. If you look at serum neurofilament light chains, which is the graph on the left, you see that in people who develop MS, Epstein-Barr virus infection results in an increase in neurofilament light chains. If you don't go on to develop MS but still get infected, you do not have any evidence of central nervous system damage. So people with MS have a unique, a different, an alternative way of responding to the virus. So how could this happen? We don't know the details, but one of the probable ways that this could be is via a phenomenon called molecular mimicry. And what we think happens is that portions of the virus protein kind of look like central nervous system proteins. So as the immune system, which is activated when people respond to the virus, when the immune system sees viral proteins, it also begins to see proteins in the central nervous system. And we know that proteins in the brain are being released into the blood after Epstein-Barr virus infection. So maybe the trauma of infection and the release of proteins into the central nervous system, from the central nervous system into the blood, activates the immune system, which then begins to attack the brain. And indeed, several groups have shown that there are B cells in the spinal fluid of persons with MS that seem to react to this EBNA viral protein. But the antibodies that are made by people who have MS, though they're reacting to the same protein, also cross-react with the protein in the brain called glial CAM. And this is unique to people with MS. So while all individuals make antibodies to Epstein-Barr virus, people with MS make a different pattern of antibodies that seems to cross-react with the central nervous system. And that may also be true of certain T cells, which also seem to have the ability, uniquely in people with MS, to kill cells that are infected. Is this proof that MS is caused by Epstein-Barr virus? Well, the answer is you have to be very cautious. There's a clear correlation between Epstein-Barr virus and MS, but that doesn't prove it causes the disease. The virus could act as a trigger for a susceptible immune system. The immune system we know is different in people with MS, and we know that it responds in a fashion that's different to this particular virus. Maybe that's the reason. Maybe MS brains have an increased susceptibility to infection, so that Epstein-Barr virus really is only a secondary phenomenon. So you have to be very, very cautious. Correlation is not the same as causation. So if you were out in the hot sun in Washington, D.C., you got an ice cream cone, and because you were out in the sun, you got a sunburn, and then you did a correlation between ice cream cones and sunburn, you would see a correlation, but it wouldn't be one of causation. So one has to be careful. So how do these observations lead to treatment? What are the implications? What does it mean in terms of particular therapies? Well, you'll say, well, gee, you know, if Epstein-Barr virus is a trigger for MS, let's vaccinate. Well, but who do you vaccinate? Do you vaccinate everybody? Do you vaccinate people at high risk for developing MS? How do you identify those individuals? As I mentioned to you, by the time you're a teenager, 90% of people have already been infected. So you have to vaccinate very, very young people before they became infected. And then you'd have to follow them for decades. Well, that's very hard. You know, Americans are a mobile population. They can be in Philadelphia when they're a child and wind up in California when they're a teenager, or how do you keep track of these individuals? So it becomes logistically a very, very difficult question. There are studies going on now. There's a company called Atara who is trying to develop T cells that can kill Epstein-Barr virus infected B cells. This is a phase 1, phase 2 study, so very, very early. It's being done in people with progressive MS. But you know, the implication is, well, if the brain is infected with Epstein-Barr virus and you're administering T cells that can kill virus-infected cells, could it make MS worse, of course? And the other thing is that if you're going to vaccinate individuals with Epstein-Barr virus proteins, it's theoretically possible, because of the different immune response MS patients make to Epstein-Barr, that you could actually trigger the disease. Not been shown, but at least a theoretical possibility. And Epstein-Barr virus and other viruses have been around for millions of years. They're not unique to humans. They're found in all kinds of mammals. Well, you know, nature is very parsimonious. It doesn't allow things to happen that don't have any particular reason. Is it possible that infection with Epstein-Barr virus in some ways may actually be protective of something? So that you vaccinate against the virus, maybe we actually may be doing harm. So these are all a bunch of unknowns. It's easy to say vaccinate, get rid of MS, but there are many difficulties with that. And I think that needs to be addressed with a great deal of caution. So let's move on then. We talked about viruses, the brains of MS people. What about COVID and MS? Well, there are certain facts that I think you all know, at least if you've been reading the newspapers, hopefully. And that is that just having MS per se, if you're otherwise a healthy individual, you not have an increased risk of either infection or severe disease. But if you have severe disability from your MS, or if you have what are called comorbidities or other illnesses, that can increase the risk of having more severe disease. If you're older, age is probably the biggest significant risk factor in terms of having more severe disease. If you have diabetes, if you have high blood pressure, if you have severe overweight, these are all risk factors that will increase your chances of having more severe disease. But MS per se has no effect on either susceptibility to infection or severity of disease. Now, what about vaccines? Well, they certainly work very, very well. And of course, the key question is, what about disease-modifying therapies? Do they have an effect on the efficacy of the vaccines? And I'm having trouble seeing my slides here. Could you make my slides a little bit bigger? Yeah, they can do it over here, if they can do it on the screen. So if you could make my slides a little bigger. Anyway, the majority of disease-modifying therapies for MS have no effect on the effectiveness of vaccines. But there are two categories of disease-modifying therapies which are very effective as treatments for MS, but do decrease the effectiveness of the vaccines. They're the anti-B cell antibodies, the monoclonal antibodies, and they're listed for you here: ocrelizumab, rituximab, ofatumumab. And it's obvious why they would have that effect. They would decrease your B cells. You don't have cells that make antibodies against the virus, and so you're going to have increased susceptibility to the disease. And the S1P inhibitors, such as fingolimod, also have a significant effect. These are, of course, drugs that sequester, that accumulate all the B cells in your lymph nodes, and so they can't get out and they can't make antibodies. Interestingly enough, though, if you look at T cell responses in people who are on the anti-B cell therapies, they're higher than expected. So perhaps you get a little bit of protection even though you don't have antibodies against the virus. So, additional things about vaccines. We know that anti-COVID-19 vaccines are safe in persons with MS. People are always concerned, well, if I get a vaccine, is it going to trigger MS? Is it going to cause a relapse? Is it going to actually make me feel worse? The answer is no. There is no persuasive data. There are no persuasive data showing that vaccines per se cause an MS relapse. Can they cause something called a pseudo-relapse? Can they make your symptoms worse? The answer is yes. If you have a fever from the vaccination, if you feel achiness and increased fatigue, yes, but these are pseudo-relapses. They increase pre-existing symptoms. They don't actually cause anything new. So that at the present time, everyone with MS who's able to should be vaccinated and get boosters. And what do you do if you're on a medication that has a suppressing effect on vaccine? Well, that's an issue that needs to be discussed with your physician or your healthcare provider. The current advice is that if you're on a medicine, for example, ocrelizumab, that you take every 6 months, you just wait 5 months until your immune system is gradually reconstituting itself and then get the vaccine. 5 months before or 5 months after your most recent dose, and then you get your ocrelizumab thereafter. If you're on ofatumumab, for example, which is administered monthly, you may want to miss a dose or two and then get vaccinated and then restart your medicine after that period of time. So basically waiting for your immune system to reconstitute itself and then at that point have the vaccine administered. Okay, let's move on then. And now I'll talk about my personal biases as they relate to MS. I don't think MS is a disease. I don't think it's a single entity. I don't think it's like pneumococcal pneumonia, where you give penicillin, everyone responds, and you get better. I think MS is a syndrome in which you lose myelin because of an inflammatory attack on the central nervous system, but pathways to it, underlying physiologic and pathologic mechanisms are different. Why do I say that? Do I have any evidence for that? Well, I think I do. People have done brain biopsies of MS individuals, and they're different. There are 4 patterns of pathology that have been described in persons with MS. The most common is types 1 and 2, but they all result in loss of myelin, but how they do so, antibodies, T cells, primary degeneration of oligodendrocytes, are all different. The end result is the same, but how they arrive at that particular endpoint is very, very different. And of course, the most obvious way is that the responses to disease-modifying therapies are so different. If the underlying disease process were the same, if it were like pneumococcal pneumonia, everyone would respond to penicillin. Everyone does not respond to these high efficacy or various other medications in a similar fashion, indicating that what's happening to that individual is different and may not be addressed by that particular disease-modifying therapy. So I think if you group MS patients and say all MS patients have to be looked at as a coherent population, it's a mistake. You're going to miss out on a lot of critical, important information. So we need to subgroup individuals. Well, how can we do that? Well, we need to look at aspects of biologic function that have not been addressed at the present time. We need to look at genes, gene function. As I mentioned to you, susceptibility genes and severity genes. We have to look at metabolism. All of us have different metabolisms. Some of us can eat anything and lose weight. Other people just have to look at a piece of chocolate and you put on 5 pounds. So differences in metabolism may be critical. We have to look at our environment. Times when you're exposed to viruses. When you're exposed to virus at age 2 is going to be different than when you're exposed to virus at age 20. Are you a smoker? Do you have other health issues, diabetes, hypertension? These will affect how your MS is going to advance. So we need to classify people with all of these different modifiers which have not been examined as part of our routine care. So of course, the critical question all of us have is how can you predict what's going to happen to a person with MS? One of the scariest things about the diagnosis of making the disease for the individual is what's going to happen to me? Well, there are certain parameters that we know about that were sort of mentioned by Dr. Shapiro that would suggest indeed that a person isn't going to do well if they have a lot of attacks, if they involve the spinal cord, if there's poor recovery from these attacks. As a group, it seems men don't do as well as women. So there are various ways of perhaps early on in the disease saying, you know, you're going to have a more significant pattern to your illness. Maybe we should treat you more aggressively. But every person's MS is different. There isn't anyone in this room who has MS who's had an identical pattern of disease. So we need to go further than that. We need to look at underlying disease processes, as I mentioned, and we have to look at why individuals vary so much in their response to disease-modifying medication. If we're going to truly personalize MS care, these are all aspects of the disease that we need to address. So how can we do that? Is there any way that we can perhaps begin to understand the different subgroups of individuals? Well, this is where we talk about systems medicine. Now, systems medicine is relatively new to medicine, but the approach has been used by engineers, physicists, mathematicians for decades. And of course, physicians are not as intelligent as those particular individuals, so it takes us longer to understand what it is that they're doing. But what they did was they have huge databases addressing different aspects of their specialties, and by using advanced statistical techniques, artificial intelligence, machine learning, etc., they were able to look at correlations, associations, ways in which these different ideas and concepts were associated and related in ways that could never be done by the human brain. And they were able to find things that were totally unexpected. And that's what's happening now in systems medicine, not just in MS. I think in all aspects of medicine, it's gradually being adopted. The problem is it's complex. So for a person with MS, for example, we have to identify their symptoms, their clinical course, other diseases that they're on, medicines that they're taking, how they respond, their metabolism, and then you compare these particular biologic findings with databases of normal individuals, and there are huge, huge databases out there. We know genes, we know protein synthesis, we know RNA databases. We have huge amounts of databases that are now being accumulated. And what's being done using computers and these artificial intelligence techniques, neural networks, which actually have the capacity to learn. You teach them something and they extrapolate information, and as they receive more information, they actually develop new concepts. We don't understand how they do it, but they do it. So then you have all of these databases, and you ask the question, this person has these particular findings, how do they relate to all these different databases? And you find associations, connections, correlations that you never expected before, providing very important insights. Are there any data to support these concepts? Yes. Computers have been used to predict the clinical course of MS. And there are 2 papers here, which I won't go into detail about. There are 2 papers that have used looking at computers and electronic health records and comparing an individual's course to other individuals' courses and coming up with predictions. Now, all of these are just predictions. They're not certainties. So what you could say after looking at these observations is, well, you have a higher likelihood, probability of having this happen to you. So these are not absolutes, but yes, they're very powerful ways of really identifying what will happen. So as with any new technique, there are advantages and disadvantages of using the system. One thing that's very powerful about them is that they're unsupervised. So what do I mean by unsupervised? All of us have biopsies, and all of us have our own intrinsic hypotheses. I think MS is the result of too much beer. Well, if that's how you feel, you aren't going to look at other things. You have a vested interest in looking at your particular hypothesis. You're going to be skewed. You're going to be biased. You're going to be influenced by how you've already established your ideas. What these systems medicine approaches are unsupervised. They have no hypothesis. They have no bias. You put in the data and you say, tell me how Mrs. Jones relates to all of these different databases, and tell me what the correlations are without any underlying hypothesis. And you come up with ways that are really amazing. This has been very successful, for example, in the treatment of asthma. They have done these systems analyses of underlying physiologic abnormalities in asthma, and they've come up with new drugs, totally unexpected, that were never even thought of by us humans, and which were discovered by these unsupervised associations. But as I mentioned to you, all of these All of these associations really are not certainties, they're probabilities. So you can say with certainty this will happen to people. And then, of course, there's always this intrinsic fault. You don't know what you don't know. So you have what are called confounding variables. If you don't know what's involved in the disease process, you're really unable to address it. So that's always intrinsic to all of these things. We always have to say, well, this probably will happen, but we can't be sure. But nevertheless, on the basis of the high probability that this will happen, I will have a certain course of action. So I think it's extremely important to address individuals as subgroups, patterns, and some additional papers that have really utilized this are shown to you in this particular slide here. This was an interesting paper out of Germany, the concept of a digital twin. So you take a person with MS, you identify all these different characteristics, their genes, their clinical course, their symptoms, their metabolism, their comorbidities, their history of reaction to other medications, their environment, do they smoke, et cetera, and you make a digital twin of that person, and then you say, okay, how does this constellation of characteristics correlate with what's happened to other people that have had similar symptoms and signs? And you come up with a correlation. You can say, well, you know, Mrs. Jones, on the basis of other individuals who have what you seem to be having, this is what is likely to happen. This is probably how you will respond to these particular medications. Again, no certainty, but a very powerful way of getting information and addressing personalized needs that are unique to that individual. Very, very powerful. Then, you've probably been hearing about this concept of prodromal MS. Have you heard about that? Things that precede the development of the disease. So there's been all kinds of observations in other illnesses. Alzheimer's disease presumably begins to occur decades before you lose your memory. Parkinson's disease, lupus, rheumatoid arthritis, all of these immunologically mediated diseases have what's called a prodrome. Things happen before the actual disease is diagnosed. Same thing with MS. Now, the things that happen to people prior to the development of MS are not well defined. It's things like more visits to physicians, more musculoskeletal symptoms, more medications for alterations in mood, anxiety and depression. So nothing hardcore, but things that seem to be a prodrome to the development of the illness. So these individuals, Dr. Charlotte Nelson and her colleagues, looked at hundreds of thousands of electronic health records, found over 5,000 people in these health records who had MS, and looked at evidence that these were different than people who did not develop MS, and by golly, showed a correlation, not perfect. A perfect correlation would be 1. So they were like 0.8, it's pretty good. They were able to predict 3 to 5 years prior to the diagnosis of MS who was going to develop MS. So it's not certain, of course, but that's a pretty good association. So what does this mean? Well, if you can identify a person at high risk for developing MS, should you intervene at that point? What can you do to modify any of these susceptibility factors that might lead to the development of the disease? That would be incredibly powerful. You wouldn't have to put them on a disease-modifying medicine. Maybe if you knew what their underlying physiologic abnormality was, you could try correcting that rather than putting them on a drug. Very powerful. So this is just one example. Moving on to even a more persuasive example, if you will. This is the work of Dr. Fitzgerald, yes. She looked at various metabolic abnormalities. Again, she compared the metabolism of MS patients to a huge database of normal metabolism and found that aromatic amino acids were different in people with MS, and that this resulted actually in an increased production of toxins. Totally unexpected. Again, this is unsupervised. This is without any restricting hypothesis that these observations were made. Extremely powerful. And a very exciting observation, actually made by a couple of researchers now, is that your initial MRI scan that you have at the time of diagnosis may allow you to predict that individual's clinical course. So they took MRI scans, followed individuals with serial MRI scans for up to 12 years, analyzed them with artificial intelligence, machine learning techniques, found that there were two patterns of disease where you had what was called deep gray matter atrophy and cortical atrophy. And if you presented with deep gray matter atrophy patterns, something you can't see, this was really interpreted by these particular statistical and analytic methods. If you presented with a pattern suggested of deep gray matter atrophy, you had a higher, statistically significantly higher risk of having more severe and more progressive disease. So your initial MRI scan, and this would be, as a clinician, I can't tell you how powerful this would be. You could predict the kind of MS that that person is going to have and the degree of severity. So how does all this all relate to MS care? Well, as with all large data sets, garbage in, garbage out. A lot of the data sets are not ideal. They've been biased. The clinical trial data sets, for example, a lot of them have an overwhelming preponderance of men, not so much in MS, obviously, but they don't necessarily represent the population at large. They don't have as much diversity as they should be. So you have to be very, very careful about what you're putting in, but they can really provide you with new insights into disease pathways. I think the classification of disease is going to be radically changed, not on the basis of do you have MS or don't you have MS, do you have attacks or not attacks. Too simplistic, it's more complex than that. What's your physiology? What are your genes? What are your comorbidities? How have you responded to different medications? That's what's going to categorize you as a unique individual with this particular pattern of demyelination. It'll provide new treatments, new insights into disease pathology, and I think will really, really revolutionize the care of MS patients. So, being a senior citizen, I would now like to ask the help of my dear friend, I wish. The best is yet to come, and babe, won't it be fun? The best is yet to come the day that you're mine. So, I think I'll stop here and be happy to answer any questions that you have. Thank you so much.
Well, here's the deal, everybody. We are going to take a break here, but not quite yet. We have 10 minutes. I'm going to ask our people to come up here, our faculty. We're going to do 10 minutes of questions and answers, and then we're going to have a 10-minute break. It may not fall out exactly that way. If during this time you need to go to the bathroom, please feel free to do so. Get some food in the back. There are some snacks in the back. And we'll be here to answer questions and take a break at the same time. Come on.
Thank you.
And I'm going to...
I guess not. that rose between two thorns thing.
Yes, right.
Okay.
Who's the rose and who's the thorn, though?
So I've got my computer here to help me get the questions that people have, and we've got a microphone there. Fire away.
Has there been any new correlation found between MS and type 1 diabetes?
Gary, do you want to take that?
Is there a correlation between MS and diabetes?
Type 1 diabetes.
Sorry?
Type 1 diabetes.
Oh, type 1 diabetes. Well, you know that, I don't think there's any correlation. There's certainly a genetic association between susceptibility to type 1 diabetes, but it's a different disease process, I think, than MS. As far as I know, if you have type 1 diabetes, you don't have an increased risk of MS, as far as I can tell. But it is a comorbidity, so it could increase the severity of MS if you should develop that at a subsequent time. But it's a very important question because obviously it's the result, we believe type 1 diabetes is the result of a viral infection of the pancreas. So are they related? I think at the moment we don't know.
Gary is one of the nation's preeminent immunologists, so whatever he says is gospel. But they're both immunologic diseases to some extent, so I think you could think of them as different antigens, different targets, different something, but the processes are related to the immune system in some way, shape, or form.
Actually, the immune system isn't involved in type 1 diabetes. No, it's a susceptibility to beta cell death by a virus infection.
Type 1?
Yes.
Well, there you go. I learned something.
Sorry.
When you have MS and you get sick, like with COVID or with another illness, 3 times in the last year and a half, I had to go by ambulance to the hospital because I got sick because I couldn't walk. I walk normally every day. I have MS, I got sick, I couldn't walk. Is that something that it happens with people with MS when they get a major illness?
That's not uncommon. I'm going to pass this to Brian in just a moment, but getting walking. But when you get sick, and when you mean get sick with a viral illness or got sick with even gastroenteritis or sometimes your core body temperature will rise a bit, and you will not be able to function as well because demyelinated nerves conduct faster and block. They block when you get overheated, as you do out there. And so it's not uncommon to see people get worse when they're sick. We call that a pseudo-exacerbation. It's not really an attack of MS, but it is appearing like an attack of MS. That's one option. The second thing is that Bill Sibley was a neurologist who passed away a number of years ago. He's the head of neurology at the University of Arizona, and he did an interesting study in which he compared people in the communities that had MS with age-matched, sex-matched people in the same community that didn't have MS, and they were looking for antecedent factors that would make things worse. And one of the things that correlated, but the only thing that correlated, was that viral infections sometimes made people worse with MS. And if you can think of the immune system revving up to attack that virus and then attacking the nervous system. Now, as Gary said, in COVID, we haven't seen that, but it's still a possibility that happens. And so that can happen. But when you get worse, then you got to get better after that. And so I'm going to pass that to Brian in terms of rehabilitation from there.
So as it relates to activity, and I think Dr. Shapiro just talked about it a little bit, we try to organize our activities so you're not getting that increased core body temperature. So sometimes looking at ways in which you can modify your activity in order to be able to do interval training, those types of things, allows individuals to gain many of the benefits of exercise and physical activity while avoiding some of those challenges related to heat sensitivity. So we'll talk a little bit more about that as part of my talk when we get to exercise, but I'm assuming that's what you wanted me to kind of address. and then working on other kinds of things in order to be able to maintain mobility and improve strength and flexibility and the like.
So we have a question here. It says, what foods help to restore myelin? And I'm going to pass this on to Mona, but I'll just say from my experience, I know of no food that will restore myelin. I love French fries. There's a lot of cholesterol. And maybe that would be a good way to, please don't publish that. Yeah. Any food?
No, I am unaware of any food that will remyelinate.
If there were, boy, we'd be on it, I'll tell you that. Would you recommend an anti-inflammatory diet?
That's an interesting question. One of the things that that's a question I encounter a lot actually, but the thing is that it's kind of an undefined diet. So we're not really sure exactly what foods consumed in what quantity and with what frequency begins to create inflammation in the body. So my general advice when I'm asked about anti-inflammatory foods, the way that foods can contribute and combat inflammation in the body is through antioxidants, which are going to be found in your colorful plant foods. And the greater variety of those that you consume, the greater variety of those antioxidants that you're going to be putting into your body and your system. So the very best way you can combat inflammation with food is with a variety of colorful plant foods. That's my take on it.
I would just like to point out that oxidants have an important role to play in your body. So it's not that they're all bad, you don't want to eliminate them, and there's good inflammation too. So anti-inflammatory can be a double-edged sword. We put people on steroids, anti-inflammatory, but they can have significant consequences. So it's always a balance between inflammation being toxic and inflammation actually being salutary or beneficial, and the same thing with oxidants too. So everyone says antioxidants are bad, but they're in our bodies for a purpose, and to eliminate them entirely may also not be that good. So just to have that perspective.
So I don't know the answer to this one. The health benefits of lion's mane mushrooms, I must admit that, are these shrooms that you get high on or what? No, they're not.
Oh,
what's a lion's mane mushroom?
While I can't specifically speak to the benefits of lion's mane mushroom, I know it's an herbal remedy, and what I can say with great confidence about herbal remedies at large is that they are not regulated. So it's really tough to know that what's on the label is actually in the bottle in the amount in which it claims to be there. You're also not sure that there aren't other ingredients in that bottle that are not on the label. So herbal remedies, I would recommend you speak to your healthcare team, maybe a pharmacist on staff, to make sure that something doesn't interact with one of your medications.
Well, I like that answer, but I was going to shift this to Dr. Foley, the lion's mane mushrooms, because Dr. Foley, by the way, last night was awarded the Giants of MS Award in clinical psychology for his decades' work in psychology. So we're very proud of Fred, but I don't think he knows about lion's mane mushrooms. This next question says, and then I have some on the computer here, association of TN, I imagine that's trigeminal neuralgia. It took me 10 minutes to figure that out, but I think it's trigeminal neuralgia and MS. If it's not trigeminal neuralgia, let me know. You know, trigeminal neuralgia, if you've ever seen it, and you'll never forget it. If you've ever felt it, you'll never forget it. It's a lancinating pain in the face, often with a trigger zone. You touch it, and a person just lets electricity. It's terrible feeling, and it is associated with MS. When it's seen in a young person, and we see that, that is a potential symptom of MS, but it's a common problem in people who don't have MS as well. And so we just have to understand that and try to make the proper diagnosis and develop an appropriate treatment plan for that. Do you have any comment, Gary, beyond that?
It can be the presenting symptom of MS.
Yeah, it can be associated, as I say.
And what often happens, unfortunately, is that you see your dentist and then you have an enormous dental workup, and it's not that at all. So there are certain very characteristic things. There are trigger points. The pattern of the pain is very characteristic, very different from a dental pain. So just a word of caution, if you know someone that develops facial pain, there's a broad differential diagnosis, and it doesn't always have to do with your teeth. And I've seen patients, unfortunately, who've had extractions and endodontic work done, and it was, of course, without any particular benefit and very expensive. So just a word of caution that this is an easy diagnosis to make if you think about it. It's, again, your biases. If you see the dentist, they look at your teeth. If you see a neurologist, they look at your central nervous system.
With this particular question, or is this a different question?
Pertaining to what you were talking about anti-inflammatory diet and all that, if you have MS and you've got neuropathy or whatever,
Neuropathy?
neuropathy, and you've got different things, and then the person goes to is an anti-inflammatory, it's ibuprofen or an anti-inflammatory, which I can't seem to live without. Then is that a bad thing for MS to take?
I'm sorry, speak just a teeny bit louder.
A bad thing to take anti-inflammatory?
No, it's not a bad thing to take it unless you have other problems like ulcers or things that it might be related to. But it may not work for neuropathic type of pain as well, because it's a different, nerve pain is a little bit different. If you have trigeminal neuralgia and you take anti-inflammatories, there's a good bet it's not going to work. Even corticosteroids may not work so well with that. We have different, we use anti-seizure type medicines for those types of pains. And so we have trigeminal neuralgia, which can be associated with multiple sclerosis, as we've all said here now. But Bell's palsy, facial nerve palsy, can also be associated with multiple sclerosis, but it's seen in people, obviously, who don't have multiple sclerosis as well. So when we see that, we look at the person's age and we ask some questions, and often it has nothing to do with MS. We just have to treat that particular symptom separately, and sometimes it does. There's a question here, Gary, about Evusheld.
About what? Evusheld?
Yeah.
Yeah, okay. I'm ready.
It's as a way to obtain protection against COVID.
Yeah, it's a combination of two monoclonal antibodies, Evusheld, and it's being used actually quite frequently in persons with MS who have been on disease-modifying therapies that affect the response to vaccines. So if you're on one of the B-cell depleting therapies, you get put on Evusheld. It's administered intravenously. It's a monoclonal antibody, and it's protective against Omicron, which is nice. So at least for this variant, who knows what the variant will be in a year or 6 months, and it protects you for about 6 months. So it is being used in people with MS who are more susceptible to COVID because of their disease-modifying therapy.
Hi, thank you for your presentation. I'm
It's
wondering,
an emergency use, yeah. It's an emergency use authorization. And for older people.
Okay.
So if you're over 65, even if you've been boosted and had all the vaccines, age, as I said, is the biggest risk factor for having severe disease. The mortality for COVID dramatically increases after the age of, say, 50. So by the time you're 90, it's 25% mortality.
So what he's saying is those of us on the panel don't have to worry about it because we're so young.
all right, when you look into your crystal ball, what do you think is the timing for when the stem cell transplants will be widely available as just part of the toolkit that we have for dealing with MS? And do those stem cell procedures show promise for people with more progressive courses as well?
So I just attended a lecture yesterday on stem cells to get the most up-to-date information on it, and you know the data is really very encouraging, but the process is very significant and severe and expensive, and it's very clear that at the moment it's not ready for everybody to be on it as a first-line therapy by any means, way, shape, or form. So it's recommended for people who don't respond to the stronger immunosuppressant medications and who have a relapsing course, even early on in the disease. It works even better if you do it earlier, if you have that picture with lots of MRI abnormalities and contrast-enhancing lesions and lack of responsiveness. It's gotten better and better as the years have gone by and the techniques have gotten better in terms of how to suppress the immune system initially and then restore the immune system again with your own stem cells. I'm going to ask Gary, again, he's our preeminent immunologist, for his opinion, but it's getting closer to prime time, but it's not at the stage where we would do it routinely. Now, the problem with stem cell for progressive MS is that lots of the problems in progressive MS probably emanate from axonal loss or axonal degeneration. And if you're doing a stem cell transplant with the kind of stem cells that will make oligo cells, that has the potential to restore a nerve, let alone myelin, but maybe the nerve itself. We're not at that stage yet. Hopefully in the future, I don't think it'll be in my lifetime, but it may be in your lifetime. But in order to stop the progression of the disease, we're there, but it has to be highly selected, and it's getting better every year.
Well, allow me to elaborate. When you say stem cell therapy, that's a huge term, and what Randy was talking about was autologous hematopoietic stem cell therapy. That's one aspect of stem cell therapy, where you wipe out your immune system. Prior to wiping out your immune system, you harvest cells from the bone marrow that are precursor cells of your blood, and then you reinfuse them after you've wiped out the old immune system, hoping that you've regenerated a new immune system. And the data look good in terms of relapses. Turns out that progression is not affected. If anything, it may be made worse by the pretreatment. Some of the drugs that are used to eliminate your immune system are toxic to the central nervous system. So you actually have an acute loss of brain tissue after the stem cell transplant, and then it continues thereafter. So yes, it's the treatment for acute relapsing disease. Unfortunately, it does not help if you have superimposed progression. You can have stem cell therapy that's replacement therapy, as Randy mentioned, for oligodendrocytes. The problem is, how do you get them into the brain to the right spots and that they don't become tumors? There have been actually studies done where they put stem cells in and they begin to multiply, and they actually cause neoplasms or tumors. So that's a work in progress. The autologous hematopoietic stem cell bone marrow replacement, that looks good if you have very active relapsing disease, but again, it's not ready for prime time.
I'm not timing this, unfortunately, so somebody has to let me know.
I think we are just about out of time, but we do have one more question here. Is that okay if we do one more?
Is that the 10 minutes time frame?
That's fine. Go ahead. Yes, go ahead.
Is that right? Is that okay?
Hello. So I have a question. I'm in the 40-year-old age group. I don't like admitting that, but...
You don't look a day over 15.
Thank you. Great skincare. So I have a question. I have relapsing remitting MS. And I go to these seminars and I go to these things, and I constantly hear the questions about what you can do, what you can change, and everybody has something different. So collectively, what would you say is the one thing that could be changed with relapsing remitting MS that can change or affect some of your outcomes? So whether it's nutrition or exercise, what collectively is the one thing?
I'll start with that. We can go down the panel, and there are a bunch of questions here that I would like to you can get up and go to the bathroom while I'll just rapidly go through them, just because I want to get as many questions as we can. It's a good question, and it's a difficult question because every single person with MS is different. If I were to have to select one thing, which I don't like doing because there's no reason to do just one thing, I would say get on a disease-modifying treatment that's appropriate for you as an individual. Every single person's different, so the treatment might be different for you than it is from the next person, because those have really made a major change in MS outcomes as we look at them over time. But that's not to say that You shouldn't exercise, and you shouldn't be on a good diet, and you should do all of those things, and we all need to do all of those things, whether we have MS or not. Is vitamin D, is that what you said? So vitamin D deficiency has been obviously studied a great deal in the past few years. If I went out on the street and I took vitamin D levels of virtually everybody out there, I would find they were all deficient in vitamin D. That tells me that there's something wrong with our levels of vitamin D. Do I recommend vitamin D for people who have multiple sclerosis in general? Yes, I do. Yes, I do. There's data that makes me feel that it's of interest, but vitamin D is a fat-soluble vitamin, so you could potentially overdose on it, but the reality is it takes a hell of a lot of vitamin D to overdose on it. So my philosophy toward those kinds of things is if it's safe, if it's cheap, and if it makes you feel better, what the hell? And so I take vitamin D even though I don't have MS, and you know, that doesn't hurt me, doesn't may not help me. Yeah. Yeah. Well, you need to talk with your doctor about that. Most of us, you need to talk with your doctor about it and see what they feel about it for you personally. The dose that most people recommend is 2,000 to 5,000 units per day. We are 30 minutes over our schedule. I just got a word here, so please go to the bathroom and we're going to continue on.
So, hello. I believe I was just introduced to you, and I don't know if anybody could hear that, so I'm going to, wait, where's my little clicker? Here we go. Take a minute to introduce myself. My name is Mona Bostic. I'm a registered dietitian, and I have a private practice in Greensboro, North Carolina. I'm also a certified MS specialist, and I've lived with MS myself for over 10 years. One of the things that I wanted to say right off the bat is that nutrition is such a topic of interest for so many people. I'm so grateful both to the consortium for taking an interest in the role of nutrition in MS, as well as this panel for inviting me to discuss that with you today, as well as I'm also honored to represent my profession of registered dietitians, which I believe are an untapped resource for the comprehensive care team. So if you have any questions that are unanswered by me today, of course ask your healthcare team, but maybe consider asking for a referral to a registered dietitian. Shameless plug is what that was. Oops. There we go. Today, what we're going to talk about is going to be a quick helicopter level review of nutrition, because we could go into a lot of different tangents, but we're not going to have time for that. We're going to talk about broadly how food can impact our overall health. We'll talk a little bit about how, at least what the evidence says right now, about how nutrition can impact multiple sclerosis. And then finally, we're going to answer a question that I think some of you, I know I've had this question. I have multiple sclerosis. Should I be eating differently because of that? It's a very popular question, so I'll take a few minutes to answer that question. But first, before we begin, let's talk about specifically what is nutrition. As humans, we eat, obviously, at least if we're doing it right, we eat, ideally we eat, because food is where we get our nutrients. That's the way our body prefers to get nutrients. But because we eat, we're all experts, right? Which means we have opinions. We have opinions about what foods are good foods and what foods are bad foods, what foods are worth paying extra for, and what foods are not worth, are not considered a value. We also have a lot of opinions about what are healthy and what are unhealthy foods. And just in case you don't have quite enough of those opinions, there are an abundance of wellness influencers out there in the world to remind you and to keep you up to date with all their most recent opinions. But unlike wellness influencers, as well as the well-intended, unsolicited advice from your well-meaning neighbors and coworkers and uncles and people at church, has anybody had that kind of unsolicited advice about you really should do X or you really ought to try Y. Yeah, so anyway, unlike those people and the wellness influencers you might see on social media, nutrition is a science. Just like chemistry, biology, physiology, anatomy, all the sciences that our esteemed panel studied as part of their education, nutrition is also a science. And like other fields of science, nutrition utilizes research and the scientific method to answer specific questions. Studies, of course, they differ in scope, design, and method, but they are used to answer specific questions. And this meeting exists and has brought us together to find out about the most recent updates in research about topics related to multiple sclerosis. So, if you're like me, it's been a while since you had high school biology. So I think it's worth going through a quick review of what is the nutrition, the scientific method, and how does that relate to nutrition research. This image is, they say a picture is worth 1,000 words, and that image kind of depicts the scientific method. It starts with having an area of interest, and we ask questions about our area of interest. We gather research related to the question, and then we have to subject those questions. We create a hypothesis, and we subject that hypothesis to experiments and tests to either prove or disprove that. And once those results are available, either we've proved that our hypothesis was indeed true, or we have not. But in either case, that information is supposed to be shared, the results of which may end up turning into our peer-reviewed clinical articles. And that collection of data helps to inform our understanding of nutrition and what's going on, but also the recommendations we make in a clinical setting. But if you are not somebody who keeps up to date regularly with the latest peer-reviewed research, you may wonder if you're up to date. But if you've been on social media at all, you're probably getting at least some aspect of that peer-reviewed clinical research. And that is going to be in the form of clickbait. The thing about clickbait is it generally starts with a kernel of fact, and then it is fertilized with hyperbole and some exciting promises and questionable headlines. And it's something that has to be compelling enough to click you out of your nephew's wedding photos and go read about that information. The problem is that that kernel of truth is seldom, what it has turned into and caused you to click on it is so far removed from whatever that kernel of fact is, it's very unreliable. And it's important to remember that the internet is kind of like the Wild Wild West, and there is no sheriff in town. So you have been deputized, and you have to kind of look after yourself and make sure that you are getting credible information. And it can be very difficult to know the difference. And as an example of this, I'd like to share an experience from my own Facebook feed, right? I'm a registered dietitian. I'm a MS specialist. I live with MS myself, and an article came across my Facebook feed, and I forget the specific percentages, but it said something to the effect of 85% of people with MS are deficient in these 8 nutrients. And I was like, wow, that sounds significant, and I wonder if that applies to me. So click is what I do. I took the bait, I clicked into it, and I read it. But here's what I will urge you to do. Somewhere at the bottom, if it's a good quality, at least somewhat credible clickbait, it will say at the bottom there'll be a reference article. That will be the click back to that original peer-reviewed article. And so I did that. The article goes on to describe how deficient everyone is with MS in these 8 important nutrients, but instead of talking about the research, they talk about how important these nutrients are in our bodies functioning optimally. So if you're reading that article, you're thinking, oh my goodness, I need to really, rev up my intake of these nutrients. But when you click into the reference article, what the actual research study said was that the diets, the intake, what people ate, 85% of the 12 people in this study what those 12 people were eating on a regular basis as they self-reported, meaning they reported what they ate. So these 12 people were reporting that what they ate on a regular basis was deficient in 8 important nutrients. Not their blood, not their person, they were not deficient, their eating patterns were deficient. But the article leads you to believe that people with MS are somehow deficient. And so there is a really fine, it's really important that you verify or click in and require a little bit more of the Facebook, Dr. Google, I sometimes refer to him as, him or her. And sometimes these things can be kind of funny, right? Wellness influencers serve up so information, it's really important to take a minute and stop and ask a question. Why is this out there? Who's benefiting from this? Who's paying for this? Wellness influencers have an enormous advertising budget, and that's primarily because their bottom line is what matters to them, not your health. So I don't know if anybody has seen the one that says kind of funny. That was a little meme that came across my social media pages a year or so ago, and it was so ridiculous that I thought it provided some humor and comic relief, right? And so you think about that. Put some, can't see it, put turmeric paste in your eyes. Avoid meat, dairy, water, and people. I mean, some of that's kind of doable, but anyway, it's so ridiculous that, of course, what it's going to do is inspire you to laugh. It's not really going to inspire you to take action. The other screen, though, is specifically, I mean, I created that image, but it is specifically from a Google search that I did. Is there a diet for MS? And this is at least one of the many things that came back. It was one of the top 3, as I recall. But what's the difference between this and the example I gave you from my own Facebook feed experience is that the article, and I can't read the title, entitled "How I Cured My Multiple Sclerosis with Diet and How You Can Too, Advice from a Naturopath, Herbs and Supplements, Can They Help You with MS," right? So when you click into that, you're thinking, I have MS. I want to cure my MS. And I eat, so maybe I can eat the things that are going to cure my MS. When I clicked into that article, there was no kernel of fact. It was just straight up opinion and mis or disinformation, depending on how charitable your perspective is on those things. But the point is, it was of no value, really. And so, unfortunately, as I said, there's no sheriff in town, and it's up to you to be able to know that. And sadly, not everyone recognizes that this mis or disinformation is out there. So I'm warning you, and I'm asking you to please make sure that you consume credible information. It's at least as important, if not more so, than consuming quality food. So having said that, oops. Another thing to remember is that nutrition is a science and eating is a behavior, right? Nutrition and the behavior of eating can be informed by a lot of things, and people in my profession certainly hope that science is one of those things. But we have to also remember there are a lot of emotions that impact our eating behaviors. There are opinions, and again, that unsolicited advice from our friends and family members that maybe we take to heart. There's that whole, I don't know, has anybody heard of fear of missing out, FOMO? You're like, well, hey, how bad can it be? Maybe I'll try that. So there's a lot of things that actually influence our eating behavior. And still, those are just a few of the things that can influence our eating behavior. At this point, though, the science around the role of nutrition in the MS process is really limited. But the emotions that can impact our eating behavior are not terribly limited. In fact, some would argue that a MS diagnosis contributes to an abundance of emotions. Sometimes they can be difficult to navigate or to feel. You know, we want to like push them down sometimes. And I believe we have a psychologist who's going to be speaking to us about that in just a little bit. But it's important to remember that while science is clinical, it's precise, humans, generally speaking, are not. We are messy. We are not robots. So our eating behavior is never going to be quite as clinical as the research might suggest. So we are not clean. We're not clinical. We're not precise. We are not robots. But the human body is pretty darn amazing, right? We are born with the ability to, look at this baby enjoying that watermelon. That kid is enjoying that watermelon. Bless his or her little heart, I'm unable to detect a gender at that point, but he seems to be enjoying it very thoroughly, and that could be due to the fact that we are born with an innate ability to know what to eat, how much to eat. We know when we're hungry, we know when we've had enough, we know what our preferences are, we know what we don't like. When I was a kid, you could not, there was not enough money in the world to get me to eat a Brussels sprout. Does anybody have kids who have those kind of preferences? Now, as an adult, I love Brussels sprouts. And that just shows another amazing thing about our human body. We evolve and our preferences change over time. It's just one of the many amazing things that a part of what makes us human. But one of the things that seems to have been happening lately is that as we age, as we grow, we seem to be getting away from our innate wisdom about what to eat, when to eat, how much to eat, things of that. We're relying more on external guidance on that point, things like diets, and again, those wellness influencers that are not therapeutic interventions by nature, but we're relying on things like fitness, a Fitbit, like we have to track our food and keep track of things, and that just kind of gets us away. It makes it so it's more difficult for us to recognize those internal cues that we are born with for navigating our eating behaviors. But food is fuel, right? Everybody knows about food as fuel. It's macronutrients, it's micronutrients, it's protein, carbohydrate, fat, it's vitamins, it's minerals, it's colorful vegetables, but that's not all that it is. Food can be challenging, right? What's for dinner? I'm exhausted and I can't feel my hands, so it's really hard to put dinner on the table. Food is expressive. It can be an expression of faith or worldview, creativity, and it's often considered an expression of love. If someone is ill, you make chicken soup. Generally speaking, it's going to be grandma's recipe because that's going to be more of a loving gesture. And food is expensive, and there is a growing number of people who are having difficulty affording food, and probably more than you're aware. Food is also a charity. It's a charitable act. We associate that with. So think about donating food to food banks. Think about donating your time to a food kitchen, for example. Food is faith. Some people they keep kosher and they recognize the parv, halal, or vegetarian eating patterns as a part of their faith. Food is safety or protection. In other words, I don't know if you've heard someone say, if I only eat clean, organic, gluten-free foods, then I will remain healthy. And if I avoid the sugar entirely, I won't feed the cancer, right? And so some of these things can really begin to interrupt our emotional health and well-being. But it's also important to remember that food is a celebration. It's the birthday cake, it's the dinner out to celebrate the recent promotion, or maybe somebody who's recently graduated from high school or college, or it's that home-cooked meal. My anniversary was the 31st, just a few days ago, and I was told that when I get home, I have a home-cooked meal to look forward to as a celebration of, I believe, 25 years of marriage. So pretty excited about that. But anyway, food is it plays a lot of important roles in our human existence. Health is but one of them. And a truly, truly healthy eating pattern is going to be built around foods that are both physically and emotionally nourishing. Connecting with friends and family, as some of the folks in these pictures are doing, is a really important part of our human experience, and it's really good for both your physical health as well as your emotional health. So, how does nutrition impact health? We're going to talk a little bit more about some of the specifics. So as we've heard from the two of the other speakers before me, we've talked about the various types of research that is out there. There's different kinds of studies. They all have a different, in other words, not all research is entirely equal. But for a number of reasons that we didn't really go into here, nutrition research specifically is very difficult to conduct. It is expensive. It's just very difficult. And for that reason, meaningful randomized controlled studies to investigate the benefits or harm require a lot of time and money, and they don't get done very often. So for example, let me say I've come to you today, I have this diet that I think is really gonna change the world. How many of you are willing to dedicate 10 years of your life to never eat the things that you love, but only eat the things that I'm gonna tell you about? And you have to do it for 10 years. You cannot diverge from that. And even if everyone in here is willing to do that, can we get thousands of other people to do that, okay? And then what happens if 10 years later we find out that that thing that everybody has agreed to do, that XYZ diet, turns out that's really harmful for health? So a lot of reasons why nutrition research is very complicated to conduct. It's expensive, and it doesn't get done very often. However, in spite of that, researchers over time have been able to create a large and convincing body of evidence, body of data and research that point to some very specific ways that nutrition contributes to human health, to our physical health, both positively and negatively. That data, that research was used to create the Dietary Guidelines for Americans. Has anyone heard of that phrase, the Dietary Guidelines for Americans? You have. Fantastic. One, I invite you all to do a Google search for the Dietary Guidelines for Americans. There's a lot of amazing information, user-friendly stuff for you to use. I'll be going through some of it here in just a minute. But the Dietary Guidelines for Americans took that research and they created advice, or they created information which provides advice on what to eat and to drink to meet nutrient needs, promote health, and prevent disease in the broader population. So, seems like good information to have, right? They were developed and written for professional audience, including policymakers, healthcare providers like us here, as well as nutrition educators like myself, and nutrition program operators. It's to make sure that they are building their advice around nutrition interventions that are going to hopefully meet the nutrition needs of the wider population. But as we pointed out, research is not all of equivalent value. This is sort of the hierarchy that illustrates the value of the strength of evidence. The research that was contributed to the Dietary Guidelines for America spans all of this. We have quite a bit of evidence to suggest that we know the kinds of things that are going to impact human health in a positive way, broadly speaking, and those that are going to impact human health in a negative way, broadly speaking. So getting back to the Dietary Guidelines for Americans, we look every few years to kind of see how we are doing as a population. How are we meeting the intake recommendations based on the dietary guidelines? You'd think, although only one of us in here has specifically heard that phrase, these guidelines are a part of a lot of information you've probably received either as in school or it's just abundantly out there. So given that it is not a new idea, it's not new information, and it's out there, my question is, how well do you think that we're doing? And this chart, although it's quite busy, would indicate that we're not doing very well, actually, as a population. Everything on blue, you can see there's a line that goes across. Everything below that main line that's blue represents a percentage of the population that is not meeting the recommended intake for that particular item. So as you can see, 90% of us are not eating enough, just broadly the category of vegetables. Somebody asked earlier about antioxidants and health. If they're in the colorful plant foods, 90% of us are not eating enough of those. And then it breaks down into the specific categories. 80% are not eating adequate dark green leafy vegetables. 78-ish% are not eating adequate red and orange vegetables. 80% of us are not eating adequate beans, peas, and lentils. And so we can go on. There are 2 purple categories where we seem to be doing quite well. Everything in purple above the line represents the percentage of the population who have either met or exceeded the intake recommendations for that specific item. And currently, our population is doing well with proteins, meat, poultry, and eggs, because 70% of us are meeting our needs in that way. And interesting, the number for total grains, that says 50%, is kind of because the refined grains and the whole grains have split the difference, right? Almost 100% of us are meeting or exceeding the recommended intake for the refined grains, while again, almost 100% of us are not meeting the recommended intake for whole grains. So again, as a population, broadly speaking, we have a lot of work to do. I like to think of that as the silver lining, meaning we have opportunity to make improvement. It's not so much that anybody should beat themselves up for it. But something else I wanted to ask, does anybody want to posit, has anybody noticed that does anything stand out to you about this information, about broadly what we're not eating enough of? Plants? Plants, right? We're not eating enough plants. We're not eating enough fruits, vegetables, whole grains, beans, peas, lentils, nuts, seeds. We're not eating enough of that. So if I was going to offer you the one thing, and if you're not already meeting 100% intake of these things, that would be somewhere I would start. Again, not necessarily specific to multiple sclerosis, but I think it will serve you well as you work on health, broadly speaking. And that was my answer to my own question. Eat more plants. And then when we look at the dietary guidelines for Americans over the lifespan, right? Are we doing better when we're very young? Are we doing better when we're in the middle of our life? Or are we doing better at the end of our life? And although we kind of are in roughly a 4-point range there, people 60 and over do seem to be doing better at meeting the recommended intake. But that does mean that roughly 37% of us are not. So again, I like to think of this not so much as a bad mark against us, but it is an opportunity for improvement. And then the question of population, not just over our lifespan, but over time, how have all of us as a population, how have we done? And I think you can look at this chart and see that we've kind of hovered around the same area. So it just really doesn't look like we have been it's not new. It's not a new phenomenon is what I'm trying to say. We have been working hard and not entirely getting across that finish line of meeting our nutrient needs with foods. So how do we translate the recommendations made by the dietary guidelines for Americans into an eating pattern? How do we take those charts and turn them into a list of things we should eat frequently? Again, the dietary guidelines for Americans, just reminding you that it provides advice on what to eat and drink to meet nutrient needs, promote health, and prevent disease. That is the purpose behind these recommendations. So what are the ingredients? And the dietary guidelines for America recommend that we eat regularly, as often as possible, more nutrient-dense foods than calorie or energy-dense foods. Nutrient-dense foods are foods that contain adequate calorie, otherwise known as energy, but along with valuable vitamins, minerals, nutrients, and antioxidants and phytonutrients and other valuable things that help our bodies to operate, function optimally. Energy-dense foods are pretty much those chips in the vending machine. They have a little bit of, they have fat, right? They have a little bit of carbohydrate, but mostly they're salt and they're taste buds, and there's really no nutrition value added in those chips. That would be an energy or a calorie-dense food example. But the eating pattern that is recommended by the Dietary Guidelines for America is widely endorsed by the American Heart Association, the American Diabetes Association, the American Institute for Cancer Research, and the Arthritis Foundation, and encourages an eating pattern that includes a variety of those colorful plant foods, vegetables and fruits, a variety of lean proteins, beans, legumes, nuts, and seeds, whole grains more often than not, and And then heart-healthy, unsaturated fats. That's going to be your mono and polyunsaturated fats, as well as low-fat calcium foods. Calcium is a really important thing for folks with MS because we are at an increased risk of fracture, especially if steroids are a part of our treatment plan frequently. So if for any reason you abstain from dairy products, which are a very good source for calcium, make sure your alternative is fortified. You can get that from other things as well, calcium I mean, but it's important to make sure you're getting adequate calcium. The things that we should be limiting, those are the things we should eat frequently. And then the things we should limit and avoid are saturated fats, sodium, added sugars. Added sugars are different from naturally occurring sugars. They're the ones that take cornflakes and turn them into frosted flakes. And they will be broken out on the ingredient or the nutrition facts label separately, so you can know that you have added sugars in your product. And then, of course, you want to limit alcohol. And then the one thing that we should all be avoiding entirely are something called trans fats. You will know if you are consuming trans fats if your product contains partially hydrogenated vegetable oil. And if you are looking at a product that does contain partially hydrogenated vegetable oil, my personal recommendation is that you choose an alternate product, one that does not contain that ingredient. So how do we then translate these list of foods into healthy meals? So we're looking at the broad recommendations for a population. Then we're looking at what do those foods include. Now we need to make a meal. Has anybody heard of MyPlate? Yes? Okay. I love MyPlate. You can find the information from them, myplate.gov. But what's great about it, and it's definitely better than the pyramid, because I don't know about you, I eat off of a plate, not a pyramid. But it's really easy to use. And let me see if I can read this. So the thing about MyPlate, this visual of breaking the plate into fourths, is it helps you to include and make sure you're getting balance and proportion. You're getting all these important macronutrients, and you're getting them in proportion to the other items on the plate, which is an important thing to consider. You don't want to leave out entire food groups or macronutrients out of your eating pattern. And again, as I say, it's easy to use. You just fill 1/4 or less of your plate with a lean protein, and then 1/4 or less of your plate with either a whole grain or a starchy vegetable. And then the entire other half of the plate there, I don't know if you can tell, but it's fruits and vegetables. So essentially colorful stuff. Colorful stuff everywhere on your plate. And that can take the place of, it can look like it does here on this MyPlate, but it can also be a mixed dish, like a casserole or a soup, a stew. It's all about proportion. Make sure that the ingredients that go into your stew pot have that kind of proportion around them. And as I mentioned a minute ago, don't forget to include a calcium source, because it is very important for bone health. And again, I'm going to ask, did you notice that 3/4 of these ingredients on the plate here are plants? That is an important thing to point out. So we've talked about broadly, we've brought it down to the ingredients, we've brought it down to a plate, so now we know how to build a meal. My question now is, how do we ensure that our eating pattern is adequate? A lot of people, when they come to me, that's one of the first things we talk about, is the eating pattern adequate? And if our collective goal is health, if we want to be healthy, instead of restricting those two things that we seem to be over-consuming, I think I would urge a message of addition to make sure that we can get better at meeting our nutrient needs with food. So I've got a chart here that talks about the different ways that we can use food to achieve adequacy, starting with food, because as I've said a moment ago, it is the body's preferred source for nutrients. So we want to make sure we go with food first. Balance, which provides the body with the proper proportion of carbohydrates, fats, proteins, vitamins, minerals, and so on. We get it in proportion and balance to each other. Variety, which is something I sometimes refer to as the true superfood. I don't know if you've heard that superfoods are foods that get their powers from social media. That's true. And so the real true superfood is variety. It's because having a great variety of the foods that you eat allows you to get a diversity of nutrients. And finally, a really important thing is flexibility. Flexibility is what has allowed humans to survive over the millennia despite constantly changing food sources and famine, food scarcity. But humans are resilient, and we have found ways to adapt. And flexibility is what allows us to eat in situations that don't ideally align with our preferences on food, and that includes things like airport food or road trip food that comes from a drive-through. But all of this adds up to adequacy, which is the whole point of nutrition, to make sure that we are meeting our nutrition needs with food. And that brings me quickly to how does nutrition impact multiple sclerosis? What do we know? So what we do know about the role of nutrition in MS is that vitamin D deficiency may be associated with increased disease activity, and gut microbiome may play a role, but what the goal is and how do we modulate that, meaning what the goal is and how do we get there, is not yet known, which means a lot of the things out there sold online, I don't know what that's based on. So if they're wanting to correct your gut, I'm not sure what that's based on, specific to MS anyway. But many questions remain. So for example, does nutrition impact the disease process? We don't know that yet. Does it impact symptoms? A lot of what we have, or the information we have around that, is anecdotal. And I never poo-poo an anecdotal experience. If somebody's having a good result from that, I'm not going to say no to that. I'm just going to say that it works for you. It doesn't necessarily broadly apply to everyone. And then, one big question that remains, at least in my mind, a nutrition professional who lives with MS, do the nutrition needs of people with MS change with a diagnosis? In other words, do the dietary guidelines for America no longer apply? Because if I've not seen any evidence to that effect, and in the absence of that specific information, I would encourage us all to continue to turn to the dietary guidelines, since those are the ones that are going to help us promote our health, prevent disease. These are the things that we want. And as I said earlier, we have much more research that shows us the impact of nutrition on our health than we do on multiple sclerosis. And by comparison, we have very little very few studies, and most of them are observational animal studies at that. Are there any therapeutic diets? That's a question I get often. Is there a therapeutic diet for multiple sclerosis? And the answer to that, I should probably define what is a therapeutic diet. It is a clinical nutrition intervention or a meal plan that controls intake of certain foods or nutrients. It is part of a treatment for a medical condition. Normally it's prescribed by a physician and planned by a dietitian. If you've ever been an inpatient in a hospital, you may have had a diet prescribed for you in the hospital. That is a therapeutic diet. It may have been the general healthy diet because you didn't have a need for a therapeutic diet. And generally, diets, and here's where the clinical air quote comes in, diets that are on the internet are not therapeutic diets. That's just a full stop, because therapeutic nutrition interventions are intended to address a specific problem and affect an outcome, to change an outcome. So again, are there any therapeutic diets indicated for multiple sclerosis? And if you define the problem as being the existence of multiple sclerosis, the answer to that would have to be no. There is no therapeutic diet or nutrition intervention that has been shown to impact the multiple sclerosis disease process. How we've got quite a bit of research about the role or the impact of comorbidities on how well people with MS live. So there is no therapeutic MS diet. However, there is a therapeutic intervention or diet for all of the comorbid health conditions listed here on this slide. And given the significant burden that comorbidities contribute to people with MS and the negative health outcomes that are associated with these comorbidities, I like to think of comorbidity management as an ideal thing to consider if you're living with multiple sclerosis and a comorbidity. So if you have MS and one of these conditions, I would encourage you to work with a dietitian if you've not already been educated about the role of food in managing that condition. That would be a good idea, something to consider. And talking about the role of nutrition in MS symptoms, as I said, I don't poo-poo any anecdotal type responses, but it's important to know that primary MS symptoms are directly related to the disease process itself and demyelination, and I'm sure the doctors can talk more specifically about that. But I'm reasonably certain that they are not related to, are not impacted by nutrient deficiencies, food sensitivities, or any of that sort of information. So, full stop. There are secondary MS symptoms which can come about as a complication of a primary symptom. So, for example, if you have inability to sleep, if insomnia is something that you deal with, or pain or bladder control that interrupts your sleep at night, that's going to leave you fatigued the next day. That is a secondary type of fatigue that maybe your physicians can help you find a way to address that other problem and eliminate this fatigue. If your eating pattern is like the rest of the folks in America where we're not eating optimally, you can make sure and address that because the best way that you can fight MS symptoms with your fork is to make sure that you are eating high quality fuel, high quality food at most of your meals and snacks whenever possible. And it's important to know that sometimes it's not just the food that needs to be changed because the food recommendations are not different. It's the adaptations, it's the planning, it's the strategies we develop to navigate what's the constantly changing new normal. So having a plan for that helps to make sure that you're able to actually prepare those meals and get them on the table more consistently. And finally, I have a snowflake there, a big orange snowflake, because folks with MS, I don't know, has anybody ever referred to it as a snowflake disease? Because we're all magical snowflakes and there's no two that look alike. So MS is that way. Our symptoms show up differently and in different degrees on different days, and no two of us are alike. So it's kind of, if you're expecting that what worked for Bob or your coworker may or may not be working for you. So it's important to make sure that your expectations, if you're going to try something, are realistic. Because diets are not risk-free interventions. If you're going to consider undertaking one of the, and I'm air quoting again, diets, I want you to please consider these questions. How does diet impact the ability for you to get that proper balance of carbohydrates, fats, proteins, all of the nutrients? How does it impact your ability to get variety? Is it potentially very restrictive and limiting in the foods that you can choose? Does it impact your ability to include flexibility? Like, for example, if you are coming to a conference like this and the foods provided don't align with whatever those food rules are, do you just starve or do you skip it? Same thing with family reunions and stuff like that. If you know the food's not going to meet those requirements, do you stay out? Because I would argue that it's better to engage with your family and friends than to adhere to those rigid food rules. And that's because of emotional wellness. Sometimes these rigid food rules can really interrupt the way we relate with food and our body and our friends, and that's just, there's no value in that. And we all know how expensive it is to live with multiple sclerosis. It is not a cheap disease. And most of the times these diets involve ingredients that are difficult to find and are quite expensive. But I'm here to tell you, the foods at your local Food Lion, Harris Teeter, Giant Food, Safeway, whatever, those are, you don't need to go far and wide or spend a lot of money just to eat well. Regular old food will do it. And again, I've pointed out the importance of sharing food with family and friends. And food is a really important part of being a healthy human. And being a human who is healthy as possible is a really good idea if you're living with multiple sclerosis, right? But food is just one part of the puzzle. Eating well cannot make up for being stressed out, sleep deprived, or sedentary. You have to do it all to make it show up. And then finally, the question, I have MS, should I be eating differently? Well, my question is, how are you eating now? Does your intake align with the current dietary guideline for American recommendations? If not, It's a great place to start. Does your eating pattern allow for balance, variety, and flexibility, all of which help to make sure your eating pattern is adequate? If not, that's a great place to start. Do you have a comorbid health condition? Are you eating in a way and engaging in other health-promoting behaviors that will help to manage that condition appropriately? If not, that is a great place to start. Because eating for health is very much like I laid out it's on this slide, but it's just kind of a reiteration of the Dietary for Guidelines for America. And so eating for MS, my recommendations, eat for health. Eat for health. And then if you have another comorbid health condition, add on to that. Make sure you know how food impacts the management of that condition, and do that. And if you have questions, if you need guidance or help, I highly encourage you to reach out to ask for a referral to a registered dietitian who we are uniquely trained and qualified to answer all of your questions and provide support on those matters. And that concludes my talk. Thank you very much. And I'd like to welcome Randy back up here.
Thank you, Mona. That was wonderful. Now I have some difficult comment to make here for a moment, but this is our 4th annual patient presentation at the consortium. And in the past 2 years, we've had a neurologist on our panel who had multiple sclerosis, and he presented himself and gave a wonderful talk. He's a nationally known fellow who kind, sweet person, and he passed away in this past year. And so we're all feeling that personally, as well as generally. I would say have a moment of silence, but we've had a video that has been made about him, and I think we're going to show that video now in his honor.
My name is Peter Wade. I'm a neurologist. I run the Mandel Comprehensive MS Center in Hartford, Connecticut, and I've had multiple sclerosis over 40 years. When I was originally had my first MS symptoms, I was a baseball player in college, and I lost the vision in my right eye, and I couldn't play baseball anymore. So I transferred to a better college so I could go to medical school to figure out what was wrong with me. And I do enjoy the fact that I can provide hope to MS patients. I just saw a patient last week, young lady, mid-20s, kind of a very blunt affect to her, but very nice, but very blunt. And so she was seeing me for a second opinion. And so at the end of the appointment, I agreed she has MS. And so I asked her, how many people do you know with MS? And she goes, none. I said, well, nice to meet you. I have MS. She looks at me and goes, you have MS? And I said, yes. She goes, but you're old. And she pauses and goes, no, you're very old. And I said, yes. And her whole smile, her world changed. Because everybody remembers the day someone told them they had MS. And it was like, my life is over. Nowadays, with all the treatments we have, the hope has turned into reality in this lady. When I was first asked to do a program to patients, I told the neurologist who I was working with that I don't want to do it because I don't want to stand up in front of these people and look okay and they're not. If I was in the audience, I'd say, why is he okay and I'm not? And at the end of the program, all the patients came up and thanked me because I gave them hope. And I had never thought of it that way. And that moment really did change my whole career in life, because if my history and my experiences can help people, then the benefits I can provide are clearly worth it. The Boston Red Sox have won the World Series 4 times during my career. So that's the happy ending to the story. So this is the team I wanted to play for. But this is the team I play for at my MS Center.
So Peter passed away from COVID, as so many people have unfortunately done in this era that we live in. but he remains in our hearts and minds, thoughts. Now I have the pleasure to bring up to the stage a fellow who I call one of my kids because I've known him for a long time. He has developed into being one of the nation's preeminent physical therapists and runs the Multiple Sclerosis Achievement Center in Sacramento, California, has been president of the Consortium of Multiple Sclerosis Centers, has been CEO of Can Do Multiple Sclerosis in the past, and is a personal friend of mine, Brian Hutchinson.
Well, it's never easy to follow a video like that, but I think Dr. Wade would want us to move on and talk about multiple sclerosis, since that's what he did for a living. We certainly do think of him often. I do want to thank the organizers of this particular program, the Consortium of MS Centers, Catamount Medical Education, and personally I'd like to thank Randy for inviting me to participate. I'd like to thank all of you for attending and participating in this, and those of you out in the cyber universe, thank you for joining us. Particular shout out to Sacramento. Glad you're watching. But what I wanted to do first is I wanted to address the question that I didn't get to answer as part of the panel. And at the risk of getting in Dr. Foley's lane, the question was, what is one thing that you would recommend? And that one thing that I would recommend is that you get a team, you get connected, that you include not only your neurologist and the nursing staff, but you also make sure that you have a rehabilitation team around you, that you have mental health folks that can help you. Don't have to always use them, but make sure that you have them surrounded. Make sure that you have a team that surrounds you. And then as part of that team, make sure that you have family, friends, and that you connect with them. If there's one thing, we've learned a lot about COVID, but one thing that we know about COVID is that it created some isolation. And so we know that if you can get connected, people are going to do better. So that would be my one recommendation, and as part of that, I'm going to talk a little bit about how you can incorporate exercise and how you can use rehabilitation professionals and exercise professionals in order to be able to formulate and add to that team if you don't already have them. So we had a little break here earlier, but feel free if you need to stand up. I would lose my, my PT union card if I didn't tell you you could move around a little bit. Those of you at home, if you've been staring at a screen for a while, at least move your neck right and left, get a little bit of movement in. So 1A that I would recommend as it relates to a particular activity is exercise. Very similar to what Mona talked about, we're going to talk about exercise in a general sense and the effects maybe that it has on comorbidities more than we're going to talk about what we know as it relates to MS. However, we do know that exercise has a key component in terms of improving fitness parameters, strength, flexibility, endurance, all of those kinds of things are really can be benefited by a regular exercise program. In addition, we know that we can improve function through different types of exercise programs. And finally, we're starting to learn a little bit more about maybe some of the anti-inflammatory properties of exercise and what the effects may have. That's not ready for prime time yet either, but as you'll see later on as we move through the process, it's kind of a low risk and potentially a high reward. So we're going to level set here real quickly as far as a couple of terms. My talk was entitled Rehabilitation. Rehabilitation is a broad term. So I'm going to focus in on more the physical side of things, and a key component of that is exercise. So rehabilitation, as you can see on the screen, is care that is to get you back to doing things in your daily life. So that may mean cognitive rehabilitation, that may mean physical rehabilitation using a physical or an occupational therapist, but I'm going to kind of focus in because physical therapy, as I mentioned, is kind of my lane. Physical activity is a broader umbrella of movement, okay? Because what do we know? The answer to disability is mobility, right? So we want to make sure that we are physically active. We want to be able to incorporate into different activities. And back when I started my training, physical activity didn't count. If you weren't in a structured exercise program, it didn't matter. If you were out doing yard work and you were doing all those kinds of things, we didn't count it as exercise professionals. Okay? We count it now. It's very much part of how you can increase your fitness and your activity level. Exercise is that subset, structured, something that you can do at a specific time of day for a specific period of time, and typically is looking at physical fitness parameters. So we're going to go back a little bit here, and we're going to look at the popular exercise programs of 1950. I did Dr. Google search, so these are the popular exercise programs that popped up on a Google search. Okay, so jumping jacks. So think about your days of physical fitness. Calisthenics and resistance training were the popular ones that were incorporated. And then there was this one called the 5 Basic Exercises, which was developed by a Canadian, Air Force veteran. So it had 5 specific exercises that you had to do specific times during the day. Jump forward to 2020, we incorporate a lot more high-tech types of things. High-intensity interval training is something that you probably have heard. HIIT training. There's a lot of information out there on that. And we incorporate that as an exercise program. Some components of, or some applications of that are things like CrossFit, TRX, P90X, and Peloton, which used to just be cycling but is now much broader and offers many more programs. So you can do a lot of these things in the comfort of your own home, is a nice thing about it. You can incorporate technology, but a lot of the end results or the outcomes are going to be very similar. And if you look at those comparisons, what we get into are some concepts that we like to incorporate as part of an exercise program. So specificity of training and functional exercise training are 2 areas that we are going to talk a little bit about here and kind of meld in some of that rehabilitation as well as our exercise. Okay? So what is specificity of training? It's also been referred to as the SAID principle, or specific adaptations to impose demands. So that is what, in essence, what it is it's our body is going to respond metabolically, muscularly, cardiorespiratory, based on the activities that we do. So the translation is we are how we train, or the outcome of what we do is completely based upon how we do it. Let's break that down even more. If you want to improve in swimming, you don't jump on a bicycle, you swim, okay? So you're doing specific activities, and that's what specificity of training is about, in order to be able to improve in those particular activities. So your body responds, muscle firing and all of those kinds of things, in order to the training that you do. So that's what we're talking about when we talk about specificity of training. Functional exercise training are looking at exercises to train your muscles to do everyday or to do activities that are going to be much more functional. So these are often rehab principles that we incorporate. So looking at ways in which we can incorporate different activities to have an end result that is going to be more functional. So a lot of these exercises incorporate multiple types of movement patterns, as opposed to lifting weights like this. We do different types of patterns. We do more twisting. We do things that we do in real life. So we do exercises that can be more functionally oriented. And that's kind of how things have moved, and that's the concept behind some of those 2020s that 2020 exercise programs that I showed you, is to improve function along with your exercise program. So if we combine those two, we look at specificity of training and we look at functional exercise training. That's really what we talk about when we talk about physical rehabilitation, physical therapy, occupational therapy, is it identifying through assessment specific activities or specific exercise programs that are going to have a functional outcome, because that's often how we are guided in ways in which we can improve someone's overall function. Exercise in and of itself often can improve some of those physical fitness parameters, which translates to function, but a lot of times what we need to do is a more specific or functional exercise programs in order to improve gait, improve transfers, those kinds of things. And I'm going to go through a little bit more about what that means and how you can break down some of those particular movements. But it's an emphasis of real-life activities because that's really what it is that you want to do, right? You want to be able to improve in those particular areas. The last bullet is an important one, and this is, I think, often where it's harder to get some of that information just through a generalized video or whatever. Often you need proper instruction because we pay particular attention to posture with these kinds of activities in order to be able to avoid injury, number one, and to get the maximum aspects out of that exercise program. So often you do need to consult with a physical or occupational therapist, exercise specialist, or the like, in order to be able to make sure that you have someone else watching and instructing you on how to go through that exercise program. You may have heard this term, neuroplasticity. It's the idea that what we can do is provide alternate connections in order to be able to improve overall function. It's one of the concepts behind neurologic rehabilitation in order to be able to improve in specific areas, even though you may have a deficit that is due to that neurologic dysfunction, in this case MS. So we look at ways in which we can incorporate, and there has been research done that shows specific exercises can improve the reorganization, the ability for nerves to fire a little bit better and to do more functional types of movements. So exercise is an important component in order to allow you to be able to return to that function. Also, kind of related, exercise and some of the benefits around cognitive function are being shown. So maintaining brain health is another popular term these days. But looking at exercise as a way of improving cognition is another way in which we do that. And one study that you see up there is when they combined exercise with cognitive training, that actually promoted a little bit more of that neuroplasticity. So ways in which we can incorporate functional and specific exercise programs are important. Okay, so that's kind of the background that I wanted to talk a little bit about regarding specificity of training, functional exercise training. Okay? So this is now we'll get into the meat of it, if you will, and how you can incorporate some of this on your own. So how do you decide? I mean, there's a plethora of things out there. There's lots of virtual programs, which are great. There's a lot more access to exercise now. There's a lot more promotion of it. That's a really good thing. But how do you decide what is best for you? And I would tell you that often you do need to consult with a physical or an occupational therapist or someone who has experience in multiple sclerosis, whether it's an exercise specialist, whether it's a rehabilitation professional, that can help you identify, number one, what your goals are. Then they can help you looking at that particular movement. Often it is improving function. We can help you analyze and break down that movement into its component parts. After we can do that, then we can start to build it up with the exercise program. So we can determine where some of those challenges or when some of those deficits may occur or may be in order to be able to then move to the next step of making recommendations for exercise. Okay, and I'm going to go through that a little bit more because that may not make complete sense, but hopefully it will when I'm done here. If you have challenges with, maybe it's a time of day thing. Maybe you say, my foot drop occurs later in the day, or my fatigue is that much worse and my walking gets worse when I'm more fatigued. Then take a video of the activity. Or have someone take a video of it. So when you do take it into that physical or occupational therapist, or perhaps it's your physician or the nurse or extended provider in that particular case, you can show them. You know, you saw me walk in today, I was fine because it's 9 o'clock in the morning. However, this is what I look like at 3 o'clock in the afternoon, okay? We all have cameras now, right? It's pretty easy to take videos, so I think it's often good to do that, to be able to identify, number one, if it's a time of day issue, maybe it has to do with heat, maybe it's your home environment. Maybe there's challenges in the backyard on uneven surfaces, those kinds of things, okay? But taking a video of the activity can be very informative for the rehabilitation professional or any other healthcare professional. And then we have this idea of closed chain versus open chain exercises. Are people familiar with those terms? Okay. So closed chain activities tend to be where a body segment is fixed, okay? And then you do the exercise. So and then the open chain is that you have the extremity in most cases is open in the environment. So the example that I will give to you of that is a closed chain activity to help strengthen the quadriceps can be a squat. Okay, so that's a closed chain type of activity. An open chain activity would be doing this type of thing. Okay, they both have their place. When we talk about functional exercise training, we do tend to move more towards closed chain, because what happens with that is you incorporate a balance component, number one. Number two, you add in the stability aspect, so you have stabilizing muscles that are having to work as opposed to sitting down in a machine and extending your knees. But safety is something that we need to take into consideration as part of that also. So again, supervising and identifying what works best for you, what will allow you to gain the goals that you want to out of that functional exercise program. We look at closed chain versus open chain activities. In addition, with the closed chain, we often are incorporating more muscle groups, not only with the stabilization, but when I'm doing this type of activity, I'm also pulling in active movement in my gluteals, okay? So I'm looking at my hip extensors and those kinds of things, which may translate better to some of those functional activities that we're talking about, okay? So when you talk to your therapist or when you're looking at these kinds of activities, that may be something that you want to consider in order to better translate to your activity. So what do I mean by all this? This is what I mean by it. Okay, so if we break down a specific movement, this particular one is getting out of bed. All right? So if you look at that, and I like this image because it shows it kind of from the lying down position to the sitting, what has to happen here? Well, one of the first things that has to happen is you have to be able to roll your hips and have the range of motion to be able to do that. Your hips and your trunk to the side of the bed in order to do that safely. So you have to have the range of motion there. So that we look at that movement, we identify maybe that's where I'm having the problems, or maybe that's where you're having the problems, is being able to get your knees over into that position because you have tightness in your hips. Okay? That, number one, informs us some exercises that we can look at doing in order to be able to set the space so you can do that. The other thing is, as you see in kind of that middle image, he needs to use his arm to push up. Okay? He needs to use the back of that arm in order to be able to push up from the bed. Okay? So what is an exercise that we can do for that? We can help with the triceps. We can do that movement in and of itself, but if the challenge is they lie down fine or they roll fine, so they have that range of motion, but they can't push up from the bed, we might need to start with some core strengthening or some strengthening of that triceps muscle or those triceps muscles. So we have exercises in which we can do that. So we've looked at these two phases of the movement in and of itself. And the last thing is you have to have your balance when you do to get to that sitting position, right? So if you're having challenges with that, or you need support with that, then we can start looking at some sitting balance activities. So we have a stretching activity, a strengthening activity, and a balance activity that we can incorporate into that movement, which is sometimes seen as a very simple movement of getting up from a lying position to a sitting position, but can be very much a challenge for people. Okay? So we can break down that movement and we can formulate an exercise program in order to be able to improve those fitness parameters that will allow you to better achieve that movement. So let's look at another one. Okay? So this guy's putting on his sock. The first thing I would tell you is maybe you should sit down and do it. Okay? So if you have a balance problem, maybe you need to look at sitting down and doing it. But even if you're sitting down and doing it, there's some things that we need to take into consideration. The other component of that is maybe you need to look at adapting that activity. So this is the image is looking at a sock aid. Are you all familiar with that? We often use it in hip surgeries, but it can also be something that if you have balance issues, leaning forward to put your sock on, or you don't have the range to get that hip up, that you can use a sock aid. Okay? So if you insist on doing it in standing, either way, we're still going to need that range of motion. So you need to be able to get your hip up in that particular position, whether you are standing or whether you are sitting, as you can see. You have to have that range of motion. So stretching in this particular case may mean stretching out those hip extensors and some of that low back. So breaking down the movement, we look at that's one of the first things that you need to do. You need to look at how we can functionally improve that activity by making sure that you have the appropriate range of motion. Secondly, we might need to look at balance activities. So again, if you absolutely want to be able to put that sock on in a standing position, and you can do it safely, then we may need to look at ways in which you can improve your balance. So you can improve the time that you have to stand on there to get the sock on. Okay? If you're doing it in a sitting position, you still have to have the balance to sit, correct? So we can look at some sitting balance activities, and this is just displaying an activity in which someone is sitting on a ball, a therapeutic ball, and lifting up things with their foot in order to be able to transfer them to that tic-tac-toe board. Okay, so these are activities that can translate into a very functional movement of something that you need to do on a daily basis. We can do that with a lot of other activities or a lot of other functions, but I wanted to give you a couple of examples of how that movement can be broken down and how you can then organize an exercise program around that. Okay? So in general, when we talk about exercise, we talk about it in essentially three categories. We look at it from an aerobic or an endurance standpoint, or an aerobic and endurance training, and I've listed the definition, if you will. Regular continuous incorporates large muscle groups. So these are things like walking, swimming, cycling, whether it be outside cycling or on an indoor stationary cycle. So these are the types of exercises that we talk about when we talk about aerobic or endurance exercises. And this can be done, by the way, as I mentioned a little bit earlier when the question came up, it can be done in a continuous bout, but it can also be done in interval types of training. Okay, so if fatigue is a big issue, or heat sensitivity may be a big issue for some people, you can do this in an interval training. So you do cycling at a little bit higher intensity, and then you back it off. Okay, you recover a little bit, and then you pick it up again, and do that in an interval fashion. So you're still getting a lot of the benefits. You can also break it up during the day in order to doing 5 minutes in the morning, 5 minutes at noon, 5 minutes at night. That's 15 minutes a day. Bingo. That's good. That counts. We also look at the importance of stretching. Stretching is often underutilized, often underappreciated. I am not the best at stretching either, so I can attest to that. It takes time. However, it can have a great benefit. We already went through a couple and how that relates to setting that foundation in order to be able to accomplish some of those functional movements. Strengthening, there's a lot of different ways we can look at strengthening. You can utilize it in a traditional sense with weights or resistive bands or other kinds of things. There was actually a poster at the meeting this week that looked at body weight and the benefits of just using your body weight as part of the training exercise program. So you don't have to have a lot of resources, weights. You don't have to go out and buy weights. You don't have to necessarily go out and buy the bands, those kinds of things. You can use just body weight for your upper extremities, and then also looking at things like squats and some of those other kinds of exercises, incorporating that into your exercise program for a strengthening purpose. Okay? We like to look at, from a functional standpoint, how you can incorporate the multiple joint, multiple plane movements, because that tends to be how we operate in life. We don't necessarily do this for a lot of things. We tend to do this. We go across planes. We have to be able to extend and flex through movements in order to be able to accomplish a specific task. For picking up the laundry basket, that's going to be a little bit different than just one joint. So we have to look at ways in which we can incorporate multiple joints, multiple planes, in order to get the most functional bang for our buck, if you will. And then balance activities, there's lots of different ways you can do that. What I would say in general about that is, again, get some guidance on how much support you may or may not need. If you have access to a pool or aquatics programs, that can be a great place to experiment with certain balance activities, because it's a safe environment in terms of falls and those kinds of things. But look at how you can incorporate some of your balance activities and get some professional advice on that. Then there's these combination types of activities, the yoga, Pilates, aquatic exercise is also one that I kind of throw into that category, because you can get in the water, for example, and you can do resistive training, you can do flexibility training, you can do endurance training, you can do balance training. You can do it all in there. And a lot of the activities that you do in the water make you have to incorporate all of those types of things. Okay? Same thing with yoga. There's a lot of components of yoga that are flexibility, but there's a lot of core strengthening that goes with yoga. And depending on the type of yoga that you're doing, you're getting a lot of other strengthening also of upper extremities and lower extremities. So there's lots of different ways in which these combination types of activities, and particularly as done in groups, can be very helpful. So looking at ways, again, in how you can incorporate that so you're not having to spend 20 minutes stretching, and then you're doing your endurance exercise, and then you're doing your strengthening. Sometimes combining all of that is much more functional anyway. So I wanted to just spend a minute talking about how you can adapt activities. And again, this is making sure that there are ways in which you can get involved. A lot of times we look at things and say, you know, I used to do that, or I was able to do that when I could walk further. But there's a lot of ways in which we can adapt activities, and I'll give a shout out to First Descents over there and Can Do MS. They find lots of ways in which they can incorporate different activities, whether it be skiing in certain situations. They do the kayaking and the surfing and those kinds of things. If that's something that's of interest to you, try it. There's ways in which those can be adapted in order to be able to participate. But there's also lots of adaptive equipments as it relates to exercise. So we have, up there on the left, we did a balance activity by setting up a very makeshift volleyball court in which we challenged people's balance. They had to bounce a balloon over a piece of tape. And you'll see a number of staff standing around those folks just to make sure that they were safe. But it was a great activity. It was fun, and it was a balance training activity. So we were able to do that for 20 minutes, and people didn't even know they were doing their balance training at that particular time. The second one on the top there shows a machine in which we can adjust those arms. So if someone's in a wheelchair and you can see that it's wide open, you can do it standing. We can put a chair there if you have a wheelchair. All of those are ways in which you can adapt activities. Again, for the more fun activities like bowling, they have the ramps that you can use if you have challenge with balance or you can't take as many steps. but you can still participate. You can still have a good time with that. And then the bottom one here on your right is an electronic bicycle, essentially. It moves the legs for that particular individual, but they can also move along with the motor. And therefore, they can get some activity with that. If they fatigue quickly, the motor takes over. So it's a nice combination, particularly for people who are starting to try to work back into some of those activities. These are some other things that we look at that are part of our center. The one up on the upper left there is a recumbent tricycle. So for people who want to get back into riding on, we have the American River Parkway, which is 26 miles of paved trails along the river. It's a great way for people to get outdoors, experience some of the things that maybe they don't have the balance now to get on their bicycle. This is one way in which they can do that. You can also attach a motor to that, or assist motor if you're doing hills and those kinds of things, in order to be able to allow you to fully enjoy that. The one on the right there is a semi-recumbent elliptical, which uses the upper body and the lower body in order for people to be able to spread out the workload and decrease fatigue, if you will, because they're spreading out the workload a little bit more. Okay? So how do you start or change? This is one of the things that, one of the questions that came through, how do I get started? I already mentioned getting a consult with a physical or an occupational therapist is a great place to start because they can help you identify what the best exercises might be for you. But it's also important if you want to look at, taking access to different areas or things that are on the internet. There's lots of things out there. Again, I'm trying to segue into Dr. Foley's presentation, not take over, but look at ways in which you can identify where you are on that scale of exercise. Am I really ready for this? And if you're not, maybe you just need some additional help, and maybe there are some things that I can provide you practically that will allow you to be able to become engaged with that exercise program. So find out where you are on that scale. Are you contemplating it? Are you already doing it and you want to kind of go to that next level? Did you used to do it and then you kind of relapsed and you're trying to get back into it? We all go through those. And that's certainly identifying where you are on that scale. It's not good or bad, it's just identifying that. And then kind of rate it. Say, am I ready to make this change? Am I willing to make this change? Do I have the ability to do it? Do I have the resources to do it? I want to join the gym or I want to go to the pool, but can I? Looking at ways in which you might be able to do that and then finding ways in which you can identify that. And then how confident are you that you can make the change? So these are some of the practical tips I think that are important. Ways or research demonstrates that group exercise can be more motivating for people. There's an accountability to that. At our center, we talk a lot about accountability buddies. So you identify someone who can hold you accountable to your exercise program or your nutrition plan or whatever it happens to be. So group activities can be very helpful. Setting goals is really important also because it gives you a purpose and a place to identify where you're going, and you can do check-ins all the time. Find activities in which you can participate. So you may identify that you want to participate in a pool program or an aquatic exercise program, but the one that is closest to you doesn't have a lift to get in, or it doesn't have a zero entry. Okay, so how can we make adjustments, or how can we look at still getting you active, or maybe there's another pool that you can look at. And know your body, particularly around fatigue and heat sensitivity. So looking at times of day in which you might want to exercise. And then monitoring your progress. So a lot of you have probably seen these terms. When we look at exercise prescription in MS, we look at frequency. And the recommendation is that if you try to do something every day, and this is where physical activity comes in. So make sure that if you're walking the dog every day, that's great. Try to do something almost every day, and then try not to miss more than 2 days in a row. The intensity, we like to use rate of perceived exertion, and there's a couple of rules that we look at. One is the 2-minute rule. It can be whatever time, or I'm sorry, the 2-minute rule. It can be whatever time you want, but start your exercise program. Go through the process. If you're feeling fatigued, live to fight another day, okay? A lot of times what you'll find is that fatigue will go away once you start getting into it. You'll get over some of that fatigue that is inertia-based, okay? The 2-hour rule is also very important. So if 2 hours after you exercise you don't feel as good as you did before you started, you probably did a little bit too much. You will recover, you'll do okay, but you need to maybe adjust your frequency or your intensity or your time, okay? So a couple of things to think about. It's not what you do on one day that counts, it's what you do every day, okay? So looking at consistency and how you can incorporate things. The 2-hour rule is an important one. If you don't feel as good 2 hours after as you did when you started, you did too much. Start low and go slow. Okay, so if you're starting an exercise program, just take it nice and slow. Increase slowly also. Don't try to go from 20 minutes to 40 minutes the next week. Try to incorporate a well-rounded program, so don't just do one thing. Make sure you incorporate flexibility, balance, strength, and the like. And then make sure that if you're having issues or you're running into roadblocks, that you seek assistance. So this is what I referred to earlier. There's lots of things around behavior change that we look at in this kind of paradigm. Things that are low risk and high reward, things that are low risk and low reward, and things that are high risk, high reward, and high risk, low reward. So exercise kind of falls right there. It's a low risk kind of activity, and it may have a high reward. Seek the assistance that you need, and make sure that you get the counsel that you need. But exercise is a good activity that everyone can participate in. So with that, I will say thank you. And while I'm transitioning out here, I just wanted to let you know that I will, I'll leave some business cards at the front. I will try to be around afterwards. If you have any specific questions, let me know. But I'll leave some with the course organizers. If you have any questions you want to email me, that's fine. Okay? I'm going to turn it back over to Alexa with the Catamount Medical. Thanks.
Thank you so much, Brian. I hope everyone is enjoying the program so far. We are going to run a bit past 5 p.m., and I just want to remind everybody to have your raffle tickets ready at the end of the program. We will be doing our raffle then. And if you have not received a parking validation ticket for either valet or self-parking, please wave me down at the end of the program, and I can help you with that. I would like to now welcome Dr. Fred Foley for his presentation.
I'd like to begin by thanking Catamount, the CMSC, and Dr. Shapiro for inviting me here today. And I'm delighted to get to spend a little time with you today, even though you're all probably very cognitively foggy and fatigued by now. So how many people are feeling cognitive fatigued right now? Right. So the last thing you probably want to hear is another lecture at this point. However, I will do my best to wake you up a little bit, and I'd like you to start by stretching a little bit in ways that Dr. Hutchinson would advise, not harming yourself, but just gently. And I'm going to teach you to breathe in a particular way. I'm going to give you a couple exercises to do today, and we might as well start off with the breathing to kind of get that oxygen into your brain. There's a way of breathing that will kind of help relax your body and your emotions. Because I'm going to be talking about mental health today. I'm going to be talking about anxiety and depression and things like that. But I also want to let you know there are ways to kind of conquer that. And there are very good treatments available for that, and some of that you can do yourselves. So, how many of you are breathing right now? Raise a hand. Okay. Those of you who didn't raise a hand, could the neighbor please take a pulse and call 911 if necessary? Okay. So you're breathing all day, hopefully, but as a professor, I'd like to give a lot of homework. So I'm going to give you your first homework assignment today. And that is, I want you to practice taking 3 slow, deep breaths, allowing your exhalation to be twice as long as your inhalation. There are many ways to do this. I do this by breathing in deeply through my nose and then out slowly through pursed lips to allow me to control my rate of exhalation. Other people do it by inhaling and counting in their minds. Inhale, 1, 2, 3, 4. Hold, 5, 6, 7. Exhale, 8, 9, 10, 11. So let's practice that now. We're going to kind of fill you with oxygen, get your body a little relaxed. We're going to do this together. That includes you in the audience out there virtually. There's no getting out of it. We'll find you if you don't do it. So let's practice that now, unless you have some medical contraindication for taking a deep breath. Okay, we'll do this together. 3 slow, deep breaths. Really stretch your diaphragm and abdomen, making sure your exhalation is twice as long as your inhalation. Ready? Go. And then just breathe at whatever is a comfortable rate for you. How many of you found that slightly relaxing? Yeah, it works. So that's your first homework assignment. To manage stress and anxiety is you're breathing all day anyway. You might as well breathe in a way that will relax you. Take 3 slow, deep breaths, making sure your exhalation is twice as long as your inhalation, 3 times a day. Prescription 1. Okay. Now I guess I should lecture something. Oh. Do you think I broke it by dropping it? Okay, there we go. So we're going to be talking about emotional disorders in MS today and cognitive problems in MS today and some things that you can do about it. Okay. First of all, it's important to kind of understand that there's a variety of mood disorders that occur and disturbances of the expression of your inner mood. But it's complex. There are many factors that contribute to the relationship between MS and emotional disorders. Genetic predispositions, for example. Can I use my thing here? Okay. There we go. So inflammatory changes in the central nervous system can also contribute to it. Structural brain lesions contribute over 40% of the variance associated with depression. A response to chronic illness. Who doesn't get upset when they get a diagnosis of MS or if they have another exacerbation? MS-related pain, fatigue, and cognitive impairment also complicate emotional disorders. And a few symptomatic MS treatments, not DMTs, but some symptomatic ones like high-dose intravenous corticosteroids can cause temporary increases in depression or mania, and occasionally psychosis. But again, these emotional responses are temporary. Okay. All right. When we look at the prevalence of mood and anxiety disorders in the MS population versus the general population, this slide depicts that several disorders: major depressive disorder, anxiety disorder, bipolar, and adjustment disorder. And if you look at the MS column on the left and then the general population column on the right, you will see that the prevalence of these disorders is higher in each case in MS than in the general US population. And one of the big problems we have in getting access to treatment for emotional disorders in MS is that they're frequently underdiagnosed, undiagnosed, and untreated. There have been studies that have shown that even when psychiatric disorders are diagnosed, in a large healthcare system, they frequently go untreated. This was a study of the NARCOMS registry, which is a patient registry, and the findings of this study indicated when patients were asked, has your doctor ever told you that you have depression, anxiety, bipolar disorder, etc.? You can see the number of responses here out of a sample of over 8,000 patients. So 4,000 patients said, yes, I have been diagnosed with depression. But out of those that said that, only 2,900 were treated for it. And so this goes across the board with psychiatric disorders in MS. Even when they're diagnosed, they tend to be untreated. And in this survey as well, 30% of participants said that they don't have depression, and yet their scores on a test indicated that they really did. So sometimes you can have depression or anxiety and not even know it. So what I encourage people to do is to let their healthcare providers know when they're distressed. Go in there and say, I'm losing interest in things that I'm normally interested in. I'm feeling sad a lot, or I'm very anxious. You got to complain about it to get it treated. And hopefully your healthcare team will ask about it to prompt you. But we find that that frequently doesn't happen. So I would encourage you all to bring that up to your healthcare team yourselves. Anxiety disorders, when we talk about the incidence and prevalence of a condition, incidence means new cases within a particular period of time. It might be within a year or within 5 years, but it counts just the new cases. Prevalence is the overall cases in the population that we're talking about. So when we look at the incidence of anxiety disorders in MS, you can see on the left there that there's only 0.64% of new cases per year. So that's a very small amount. But when you look at prevalence, the overall number of cases, on the right half of the screen, you can see that about 22% of MS patients have an anxiety disorder. But the amount of anxiety disorders varies widely depending on the sample that was used in the study that was used. Okay, another thing that can occur in MS is something that we call pseudobulbar affect. And basically what this is, it's characterized by sudden and brief or exaggerated and uncontrollable expressions of laughing or crying that may be not congruent with what you're feeling internally. So you might not be feeling funny internally, but you burst out laughing. Or you might not be feeling sad inside, but you burst out crying. So, and this is frequently associated in MS with greater disease severity and may be associated with cognitive problems and frontal lobe lesions as well. However, this can also overlap with depression. You can have both depression and PBA. But there are treatments for both depression, and there's an FDA-approved treatment for PBA that combines two different drugs, dextromethorphan and quinidine, that can help reduce the symptoms of PBA. Treatment of depression in people with MS. First, I'm going to stop and take a 30-second pause. Do you all remember your first homework assignment? Okay, good, because I'm going to give you more. All right. In terms of treatment of depression with MS, there are a number of treatments. Psychotherapy. A particular type of psychotherapy has been found better than some other psychotherapies, and this is called cognitive behavioral psychotherapy, particularly delivered individually via either in person or via the telephone or via telehealth. there's a number of randomized trials that have found that this is a robust treatment for clinical depression in multiple sclerosis, and it has a good effect size. In one study, it had an equivalent effect size, that meaning impact on depression, the same as antidepressants did. But unfortunately, in that study, fewer people could tolerate the antidepressants. So if you get depressed, you might want to try an antidepressant first, go to your healthcare provider, and if that works, great. If you still have some residual symptoms, get cognitive behavior psychotherapy and ask for a referral for that, because there's pretty good evidence there that it works. Also, as Brian Hutchinson mentioned earlier, there's a growing body of evidence that suggests exercise, particularly aerobic exercise, can impact depression in MS and also anxiety. So the jury isn't fully out on that yet, but there's a growing body of evidence that's suggesting that one study found that engaging in aerobic exercise several times a week was equivalent to taking an antidepressant in terms of its impact on depression. So again, you might want to consult your physical therapist for a good exercise program for you. Treatment of anxiety disorders in MS, data from controlled trials are extremely limited, but these are some of the interventions that have been in controlled trials, including mindfulness-based stress reduction, relaxation training and cognitive behavior therapy, biofeedback when it's added to relaxation and other approaches, and internet-delivered behavioral intervention to increase lifestyle physical activity and exercise has also emerged in the literature as being helpful for anxiety disorders. How many of you have ever felt anxious? Maybe once or twice in your lives, right? Maybe every day, maybe every minute. So I want you to think about something, because one of the things about cognitive behavior therapy is that it observes that your thoughts cause emotions. Anxiety is the feeling that you feel when you expect something's going to happen and it's going to be bad. So anxiety, there's always an expectation linked to anxiety of some kind of negative outcome in the future. So part of what we do in cognitive behavior therapy is we get people to identify what are those expectations of that negative thing in the future. I'm having an exacerbation, it's all going to be downhill now. That's an example of one I've heard a number of times. Well, when you're feeling anxious and you're thinking something like that, you've already projected yourself into the future, that the bad thing has already happened. That's the way it feels. So what we get people to do is examine those expectations. How many here have ever made a mountain out of the proverbial molehill? Kind of exaggerated some anticipated negative outcome, catastrophized about something. So part of CBT helps you get that under control. Part of CBT kind of brings you back to the present moment. If you're fully engaged in the present moment, and we do call that mindfulness training, you're not going to be anxious, because anxiety is always about the future and future expectations. So I just wanted to explain to you some of the mechanisms of cognitive behavior therapy so that they're not a mystery to you. Okay. And we found in our studies, and others have found in their studies, that if we can get you to change your thinking and get you to change your behavior, this leads to increases in your coping abilities, your problem-solving abilities, your kind of ability to handle and regulate your emotions better. And these increased coping efforts that we teach in cognitive behavior therapy are highly correlated with improvements in mood, lower anxiety and depressive symptoms, and in one of our other studies, better partner communication, emotional connectedness to your partner, and marital satisfaction. So, some of the things that we're talking about, in CBT, and some of the things that we know about from MS patients, that many don't develop depressive disorders, many don't develop anxiety disorders. And this is one of the things that has been coming revealed in the literature, that there's a capacity that we call resiliency. And resiliency is the ability to manage well in the face of trauma or illness-related losses. And one of my former students developed this MS resiliency scale, and she found in her research that there were these 5 components to it. Emotional and cognitive strategies. Well, those are the things we teach in CBT. Physical activity and diet, that emerging kind of evidence for aerobic activity, kind of helping regulate mood. And as Mona said before, the importance of kind of a good diet towards overall health and well-being. And what also emerged was MS peer support was an important factor, as well as support from family and friends. So these were the main components, and spirituality was also present. So if you can enhance these components, or what we're doing now is evaluating how high and how low MS patients are on these different elements of resiliency, and seeing if we can develop interventions to enhance each of these, to increase their resiliency so that they will be less vulnerable to these emotional disorders, or better able to improve and deal with them. Okay, there's an increase in bipolar disorders in MS, and that occurs in MS, although some of these statistics about bipolar are probably biased, because some of these cases were after they were temporarily induced in a hypomanic episode following high-dose steroids. So the prevalence is probably lower than what is indicated on the screen. Okay. I also want to talk to you briefly about cognitive impairment in MS. So how many of you think that your cognition isn't the way it used to be? Okay. The estimated prevalence of cognitive changes in MS is between 34 and 65% of MS patients, and among children with MS, it's about 1/3 of children have cognitive changes. And this occurs in all MS phenotypes. We see it also including in CIS before there's a diagnosis of MS. It's highly variable in severity and progression. Some MS patients ask me, oh my goodness, is this going to be like Alzheimer's? Am I going? And I say, no. The cognitive changes in MS tend to be more mild to moderate and not as severe as you would see in dementing illnesses like Alzheimer's disease. The cognitive symptoms that typically present in MS, the most common one is information processing speed, and the second most common one is memory. So when your axons become denuded, as was stated before, that slows or impedes nerve action potentials in the central nervous system. This slows your ability to process information. So it makes kind of sense that information processing speed would be very common. And we know once your information processing speed is slowed, that can affect memory and other cognitive functions. And other cognitive symptoms may include complex attention. How many of you have trouble multitasking these days? Okay. Executive functioning, which includes your cognitive flexibility, your ability to rapidly think and problem solve. Verbal fluency. How many of you have trouble finding the right word at times? Okay. Visual spatial perception. If you find yourself getting in more fender benders, that might be a signal that that's going a bit. And social cognition is also affected in MS. And what that is, that's the ability to read other people. It's the ability to kind of 90% of our judgment about others, about what they're thinking and feeling, comes from visual cues, looking at their facial expressions, their body expressions. And so in MS, we know now that this, what we call social cognition, can also be affected and impacted, which can make it more difficult for you to relate easily to others and to understand others. We know that compared to relapsing versus primary progressive MS, what this slide indicates is just that there tends to be more cognitive problems in persons who are diagnosed with primary progressive than relapsing MS. So, and we know that cognitive impairments and changes do impact daily functioning. It affects work, school, reduced participation in activities of life. It can affect your money management skills, or it can sometimes impair your driving ability and affect other things. And understanding cognition in MS is complex. Depression could affect it. Fatigue can affect it. Anxiety can affect it. You know, one of my students found in a study that the way information processing speed largely impacts memory is it works through anxiety. In other words, if you're anxious, information processing speed slowdown will be have a greatly accelerated impact on memory. So now we know when we're doing cognitive rehabilitation, we assess carefully for mood, like anxiety and depression, because we want to fix that first, so that then we can get to the cog rehab part that will kind of more directly address, you know, the residual cognitive issues. So yeah, there are a variety of treatment modalities for MS-related cognitive impairment. That's the good news. Just as there are effective treatments for mood disorders, there are treatments for cognitive disorders. There's still a growing body of literature on this to determine whether it's effective and for what is the right patient for the right kind of cog rehab. So again, we're still a little bit in the dark about that, but there's constant research on this that will hopefully help us further along our knowledge about this. And as I said before, growing body of knowledge that exercise can impact cognition. The exact mechanisms aren't known yet, but it might be mediated by increased cardiorespiratory capacity and fitness. There's mixed results on pharmacotherapy for cognition, so more and more providers are leaning away from that now, since the evidence isn't strong for that. There's increasing good evidence that a particular type of memory rehabilitation in MS is effective. There's a technique called the modified story memory technique, which basically involves kind of associating things you want to remember by putting it into a story or associating it with visual imagery. And there have been a number of studies that have shown now that this improves memory and verbal memory in persons with MS. And a couple of studies have shown on functional magnetic imaging resonance studies of the brain that there's increased connectivity between regions of the brain, you know, that's associated with those improvements in verbal learning and memory. So, Dr. Shapiro mentioned hope before, and I just wanted to take a few quotes from my patients, you know, that I worked with about what hope means to them and what I have learned about hope from my patients. Hope is the conviction that I will accept what I cannot change, that I will adapt to losses by making sure I'm invigorated by opening new doors in my life as I realize and accept that I must close other doors. Another patient. Hope is acceptance of the reality that I am always a vital human being with the mission of making my presence on this planet beneficial in some way. Hope means being a success, and I know I am successful if I can laugh at myself or at the ridiculousness of my life every day, finding humor in the face of anything and everything. That gives me hope and can sustain me through anything my MS does to me. What I would like to do now is teach you one of the components of CBT, which is a relaxation exercise. It's how many of you would like to try to learn a meditation exercise right now? By a show of hands. Okay, all right. It looks like most hands went up. So those of you that don't want to learn, that's fine. Just kind of doodle or check your cell phones or do something else for the next few minutes. So, the reason I started with that breathing exercise is breathing is very important during relaxation and meditation. So I'm going to ask you to take deep breaths a couple of times during this exercise. And I want you to do it in the way that we said earlier. I want you to do it by inhaling deeply, expanding your abdomen and diaphragm. Kind of hold your breath for a couple seconds, making sure your exhalation is about twice as long as your inhalation, either by counting in your head, 1, 2, 3, 4, hold breath, 5, 6, 7, exhale, 8, 9, 10, 11, or just slightly pursing your lips on your exhalation to control your rate of breath. A couple of other things about meditation. Be physically comfortable. So if you have an itch during it, scratch it. If you're in an uncomfortable position, get comfortable. It's also helpful, if you stretch a little bit before you try a relaxation or meditation. You want to loosen your muscles a little bit if you can. Another thing about it, try not to cross your arms or legs. When you do so, it kind of puts pressure on your vascular system, and this type of meditation kind of induces peripheral vasodilation. And that's what we want to do. We want to induce peripheral vasodilation, which is part of the relaxation response in the body. Okay, the last thing I want to tell you before we begin our exercise is that your mind is going to wander. Think, how much have you been fully present in this room today? And what % of the time has your mind wandered elsewhere? And that will happen in our brief 5-minute meditation exercise. So when you're distracted by anything during this exercise, what I would like you to do is be the objective observer of your own subjective experience. What I would like you to do is simply take note of what the distraction was. Oh, the sound of his voice distracted me, or that other noise, or, oh, there's those worries popping into my head again, or what I'm doing tonight, or whatever comes in, or I'm so exhausted. Whatever comes into your head, just take note of it, and then gently return your attention back to the exercise. It doesn't matter how many times your mind wanders, just take note of each one. Okay, you have your set of instructions. Are you ready? Okay, let's all meditate. First of all, if anyone in the audience virtually is standing up, please sit down. Okay, get comfortable. And stretch your muscles a little bit, if you can, in safe ways. Okay. I'm not a physical therapist, so I can't advise you on this. But, okay. Now, what I would like you to do is close your eyes. Get comfortable, close your eyes. And I would like you to simply focus on relaxing the muscles in your body, beginning with the muscles in your forehead and scalp. Picture the muscles in your forehead and scalp becoming smooth as you allow them to relax just a little bit more. Allow the relaxation to flow down into the muscles of your eyelids. Eyelids becoming slightly heavier and heavier the more and more relaxed. Picture the relaxation flowing down into the muscles of your jaw, a place that we frequently hold so much tension. Allow your jaw to hang a little more limp, a little more loose, just a little bit more relaxed. Picture the relaxation flowing down into the muscles of your shoulders, your upper back. Imagine it flowing down your arms, into your hands and fingers. Some people can almost imagine the tension flowing down from the top of their heads, down their arms, with the tension dripping out the ends of their fingertips like drops of water, leaving the body as you allow your muscles to relax a bit more. Once again, take a slow and deep breath allowing your exhalation to be twice as long as your inhalation. Really stretch your abdomen and diaphragm, slowly exhaling. Picture the relaxation flowing down your back, lower back, down into your abdomen. Picture it flowing down into your lower body, your glutes, your legs, calves, even the muscles of your feet and toes, becoming just a little bit more relaxed. Scan your body from head to toe, relaxing those muscles. Forehead and scalp smooth, eyes heavy, jaw loose, shoulders loose, let them drop. Chest, back, abdomen, lower body, legs, just a little bit more relaxed. And as you're allowing your body to relax like this, I want you to focus on your breathing cycle. Notice that each time you begin to exhale, there's a natural relaxation, a natural letting go that occurs in the body. Focus on your breathing cycle. And in your mind's eye only, say the word one silently to yourselves each time you exhale. There will be many distractions from keeping your muscles relaxed, focused on your breathing, and saying the word one silently to yourselves each time you exhale. Do not be concerned by any distractions. Simply take note of each one, and then gently return your attention back to relaxing your body, back to saying the word one silently to yourselves each time you exhale. I'm just going to allow you to practice this quietly for 1 minute. And once again, I would like you to take 3 very slow, very deep breaths, allowing your exhalation to be twice as long as your inhalation. And now, I'm going to count backwards from 5 to 1. And as I do so, you will allow yourselves to feel increasingly refreshed, relaxed, and alert. 5, 4, 3, eyes open. 2, 1, refreshed, relaxed, yet alert. Take a deep breath and stretch a little bit. How many of you have found that a little bit relaxing? Okay, about 80% of people like this, and about 20% of people don't. And that's because we're human beings, we're not machines. Not every one thing works for everybody. But the point I'm trying to make, if you did find this relaxing, it means this is a good approach for you. Learning how to simply meditate. It took us about 7 minutes. It didn't take us long, to do it. So it doesn't have to take a big bite out of your day. But if you practice this and practice the breathing techniques that I told you, you will be better able to regulate your emotions. So I see that my time with you today is up. So I thank you all for being here today, for participating, and enjoy the rest of your day and weekend.
The Consortium of Multiple Sclerosis Centers and Catamount Medical Education would like to thank Bristol Myers Squibb for their generous support of this program. This support has made it possible for us to provide this valuable education program for people living with MS and their care partners.